Hello everyone. Can you guys hear me?
Yes, yes.
Awesome. Okay. I was just giving everyone a chance to join. All the guys that you have black screen, if you can switch on your cameras, that will be great. Awesome. Okay. So without any further delay, let's start. I think you guys know me very well by now, but just a very quick introduction. My name is Samina. I'm one of the GI fellow at University of Alberta, an international medical graduate like all of you. Did my internal medicine residency at University of Alberta, and then I matched to GI. So currently, I'm doing my fellowship here. Today we will be starting cardiology. That is the first topic in NAC-OSCE. In NACOSCI, I think you have to study smart instead of studying very hard. You already studied very hard in QE1, for those of you who already taken your QE1. For NACOSCI, it's mainly developing your approach towards most common presenting complaints. Um, and these presenting complaints are everything that we see kind of like a bread and butter of family medicine or internal medicine. You do not get a lot of complex cases in NACOSCI. They are just evaluating you at a level of final year medical student, Canadian medical student. So you just need to know the basic approach towards all the presenting complaints. So in when we talk about cardiology, there are not a lot of things that you have to prepare, but one thing which is certain that you always get a case from cardiology, like always get a case from cardiology. It could be anything, but one case from cardiology is must. So the typical cases that you get the acute coronary syndrome, and you can see that I put STEMI, non-STEMI, and unstable angina in the bracket. And the reason is because the management slightly different for each one of those. Then we have stable angina, acute pericarditis, heart failure, atrial fibrillation, hypertension, syncope, peripheral arterial disease, and PPPV. These are typically most commonly tested topic on cardiology. In terms of the reason I put PE, GERD, or panic attack up in the first line, just like the differentials of chest pain, that with chest pain, you can have one of these differentials as well. Similarly, when you have syncope, the
Uh, Sorry, Dr. Simon, excuse me. We can't see your screen.
oh, you guys cannot see my screen?
No, we see you, but the
No,
no, it's
we
not
cannot.
actually.
Let me try again. I will try it again and see if that works. Can you guys see now?
Yeah.
Yes.
Yes.
Awesome. Thank you, Mushtaba, for letting me know. Okay, so I was telling you the reason I put the PE, GERD, or panic attack here because these are some of the like with chest pain complaint, you can get some of these differentials. Similarly, with syncope, the differentials are vast. It's really so many things that can happen with syncope, but the most common tested topics are orthostatic hypertension, aortic stenosis. Sometimes they also give you atrial fibrillation. Atrial fibrillation can give you as a someone presenting with palpitation, but sometimes they give you atrial fibrillation also someone presenting with syncope. Once we will be doing all of these cases, then you guys will be getting to know more about these topics. So the presenting complaints that typically we covered in cardiology, of course, chest pain, shortness of breath, palpitation, syncope, leg pain, and bilateral leg swelling. So we will do a case and then we'll talk about it. Um, Tuvarega is, can you correct me? How do we pronounce your name?
Dwarka.
Oh,
Can you
it's
hear
fine.
me?
Yeah. Okay, Tuvarga, I'll give you the first case. I know it's the first class. I'm not expecting you to master anything, but let's try.
Sure.
I'll give you 2 minutes to prepare. Okay, you can go ahead, Tuvarga.
Knock, knock. I enter the room and give the stickers to the examiner. Hello. I'm Dr. Sudan, one of the physician on this emergency department. May I confirm your name and age, please?
I'm Raymond, Raymond Jackson. You can call me Raymond, and I'm 60 years old.
Okay, Raymond. I understand that you have a chest pain. So
Yes.
how long you have been suffering from chest pain?
Um, it's been 1.5 hours.
Oh, okay. I'm sorry to say hear that. And is it okay to continue for a few discussion with you? Is it, are you comfortable enough to talk with me?
Yeah, that's fine.
Yeah, sure. Okay. So you said you have suffering from chest pain for 1.5 hours. So,
Mm.
but what were you doing at the time?
My son is moving his house, so I was helping him loading some stuff, and all in sudden I started having this pain.
Hmm. So from the time, is the pain is continuously there or is on and off?
It's constantly there.
Mhm. Okay. So, 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 is there anything which makes this pain worse?
Um, I haven't been doing anything because when I started having this pain, I just stopped doing what I was doing and sat on the couch. That didn't help. My wife gave me Tylenol. That didn't help either. And then my son just drove me here.
Mhm. Okay. Which anything which makes the pain better?
Nothing. I just tried Tylenol. It didn't help.
Mhm. Okay, sure. Then, okay, in the scale of 1 to 10, how would you rate this pain?
It's 8.
It's very severe, I understand. So, what kind of pain is? Can you just describe the pain? What
Uh,
kind of pain is?
It's like squeezing pressure.
Mm. Mm. Okay, sure. Then, um, um, do you have any other diseases in the past? Have you ended up?
Yeah, I have diabetes, and I'm taking metformin and sitagliptin for that. I also
Mhm.
take a pill for my cholesterol.
Okay. So, when was your last visit to your physician, family physician?
I haven't seen in like 8, 9 months.
Mm-hmm. I hope and you do you have the refillment of medicines through
Yeah,
these days?
yeah, I do get my refill.
Mhm. Sure. Okay, then few more things about your lifestyle and behaviors. Are you active throughout the day? What about your regular exercise?
Um, I don't exercise much.
Mhm.
Sometimes like if my wife is not walking the dog, I do that, but that's like once or twice a week for maybe 35 minutes.
Mhm. Okay. It's kind of a personal question, but it's a common question I asked from everyone. Do you smoke?
Yeah, a pack a day.
Mhm. Okay, what about alcohol?
Um, a glass of beer maybe twice a week.
Mhm. Okay. Did you tried any illicit drugs in the
No,
past?
no,
Okay. So, so you said you have medications, and what about allergies? Do you have any allergic for food and drugs?
no,
Mhm. Okay. Have you underwent any a recent hospitalization in the recent past?
no,
Yeah. Any surgeries in the past?
nope.
Okay. Okay. Then, so how do you support yourself financially?
Um, I work in a construction company. I have my own little setup.
Mhm. So how your working environment is so stressful or it's comfortable enough?
No, it's manageable.
Mhm. Okay. Um, then, mm, yeah, sure. So, just and during this period, did you hurt yourself with any trauma to your chest and anything?
No.
Mhm. Okay. So, okay. So, did you have your blood pressure checked recently?
Blood pressure. Yeah, my blood pressure was 145/90, 140/90.
Mhm. Is it the same? Is it the regular blood pressure? I just want to know that is a little bit high blood pressure. So is it
Oh, yeah,
normal?
today it's a bit high, but usually like 140, 145.
Mhm. Okay. So what about your diet? It contains any cholesterol high diet? So what about your fruit intake? Can you just discuss about it?
I eat everything, but I would say I like meat, so mostly my diet is composed of meat.
Mhm. Okay. Mm, yeah.
Okay.
Then,
What are your differentials?
so is my first differential diagnosis is acute coronary syndrome, and then second one is aortic dissection, as he's having borderline high blood pressure, then peptic ulcer disease.
Okay. How would you investigate?
So first I want to order a ECG. Then I want to see if there are any ischemic changes there. Mm, Then I want to order the full blood count, e, CRP as well, and serum electrolytes and blood urea, serum creatinine. And then we can, yeah, then I just want to, following the result of ECG, I can, if the change is ischemic, then we can continue with the echocardiogram to confirm that. So is the ECG to so I can see ST elevation ischemic changes at V2, V3, and V4 as well. Maybe. So it's kind of anti-DMI. So the troponin is yeah is elevated.
How will you
Of-
manage the patient?
So mm, I will put him. I will admit him first, and then I will give oxygen and put the pain morphine, IV morphine, and then we'll give the status of uh, mm, uh, clopidogrel. We usually for clopidogrel, and then mm, we can refer this patient to the cardiology unit.
Okay. Thank you, Varga. One more question. When you're discharging the patient, what medication you will be discharging him, and if there are any special instructions that you would like to give him?
Yeah, along with his usual medication for the diabetes and high cholesterol, then we have to prescribe uh, antiplatelets, clopidogrels, and then nitroglycerin for if any acute emergency purposes.
Are you going to give him one antiplatelets or two?
Yeah, 60 years, man. Then we can go for double and platelet therapy. Yeah.
Okay. Instructions on discharge?
Yeah. For the week, he can do mild like movements. He can move around, but not this vigorous exercise or vigorous activities. Then you have to have a mild carbohydrate diet, not a heavy one. Then he have to try quit smoking, um, uh, and we have to arrange a counseling session for the smoking counseling as well. And then for when for the return to the work, we have to discuss how if he's comfortable enough, if he's not from starting from small works to desk the work to the vigorous type of works in a step out manner. Then we have to discuss it in a further and reassess, and then thereafter he can return to his work in
Okay.
a way. Yeah.
Thank you, Tavarka.
Thank you.
Anyone can answer if the same patient or a different patient presenting with a similar picture, but they have taken cocaine. How would your management would be different from the current management?
So I think because in cocaine we usually have the spasm, so we don't do reperfusion. If I remember correctly, we give them benzodiazepines, if I'm not mistaken.
Yes, benzodiazepine is the first
Yeah,
line. What you can give as a second line if there is ongoing ischemia?
nitroglycerin.
Yeah, nitroglycerin can be given, but
Yeah.
calcium channel blockers. What is contraindicated?
Beta blocker.
Beta blocker is contraindicated because that will give you worsen your coronary spasm. Okay, so Tivarga, I won't be giving you detailed feedback. This was the very first case, so well done. Just to be brave to present in front of so many people, but you will see the difference from first case, first class versus towards the end of the case, how much you will be improving, and that's the whole purpose that we are here together. Now, I will talk about two things. First, I know that I sent you guys a book to like how to take a good history on that. So I will leave you guys to kind of keep referring back to that and keep studying and keep memorizing and practicing with your study partner to become an expert. But just to give you a quick overcap of the history taking will be like, whatever is your case, it will be same across the board. You will be asking the same question again and again. So whenever anyone presenting with anything, so for example, in this case, a gentleman is presenting with chest pain, right? So a person is coming with the chest pain. So the next thing is, when you're entering the room, definitely you will be greeting the examiner and then later on greeting the patient, but first greeting the examiner and handing over your sticker to them so they can put it on your scoring sheet, so your score do not get mixed with anyone else's score. So after that, you will proceed to the patient and you will sit down. If mostly patients are sitting, sometimes patient can be on stretcher and then you just have to stand next to them. Most of the time they are sitting on a chair, so you will be sitting just opposite to them. There will be another chair. You will be introducing yourself that, hi, my name is Dr. Khan. I'm a physician on call today, or I'm the resident on call, whatever is the role that they have defined you on the question. And then I always like to ask open-ended question that what brought you in today, or how can I help you today? The reason for open-ended question, one, you will be scored on that. So throughout your checklist, they will have a question that a candidate was asking open-ended questions. So you have to make intentional efforts that you ask more and more open-ended question to get it covered. Mostly how it get done, that open-ended question followed by a closed-ended question. So how can I help you today? Or what brought you in today? Well, I'm having chest pain. Tell me more about it. So I didn't say, oh, I'm so sorry or anything. I just said, tell me more about it. And the reason is, yes, we will have score for empathy as well, but our empathy should be more natural, and empathy shouldn't always be with I'm sorry, or like, expressive this way. It can be your body language, your facial expressions, your physical cue as well. And then you don't have to overdo your empathy, that you just keep repeating, I'm so sorry, or I'm sorry. So I'm having chest pain. So honestly, I would like in my real life, I always ask me, so right now I still don't know what is going on. And just instead, oh, I'm so sorry to hear that. I feel it very immature, or like a pretty premature thing. It's like, tell me more about it, because I really want to know what's going on with the patient, right? Well, this pain started around 1.5 hours ago. I was helping my son, and then all of a sudden I started having chest pain. That seemed quite frustrating. So this is my empathy here. So instead of like in the beginning said, I'm so sorry to hear that, I said, okay, tell me more about it. And then they said, and I developed this pain and it didn't resolve. And then my wife gave me Tylenol, didn't happen. My son drove me, or seems frustrating. So you see that I use the word that I acknowledge that they are going through this, and I said this seems frustrating. Pardon my voice as well. I'm going through a flu, as many of you may be, because it's the winter in Canada. Anyway, and then it seems quite frustrating. would you be okay if I ask you a few questions and they will be like fine? So instead of like, are you comfortable? Because definitely if they're having chest pain, they are not comfortable. So, but I just want to take permission to proceed and just want to acknowledge that I know that they're in pain and everything. So would you be okay if I ask you a few questions? Yes, sure, go ahead. Okay. So you told me about this chest pain. Is this the first time you're having this chest pain? And this is exactly every single presenting complaint will go the way I'm describing you right now. Like whatever is the chief complaint, tell me more about it. They told you a little bit story, you put in a little bit sentences there that okay, I understand it's frustrating. And then um, the first thing that we do is onset, setting, course, frequency, and duration. So onset, we know that it started 1.5 hours ago. Setting, we know that they were helping the son and they got it. Frequency, we ask them, is this the first time you're having this chest pain? Now, if they say yes, great, go ahead. But if they say no, I had it in the past as well. So then ask them, what happened in the past? So now here, if there is something chronic going on, and again, as I said, this the way we are taking history, it implies to everything. So if they say, I had it in the past as well. So what happened? Tell me about that. So nothing. I had pain and I took rest and it to go away on its own? Or have you seen a doctor at that time? No. Any further investigations being done? No. Or do you have a diagnosis? No. So these are the questions. If the patient had a similar chief complaint in the past, you can quickly ask this question. And this help you in the cases where you usually get exacerbation. For example, someone with congestive heart failure, usually the case is now they're coming in the emergency with exacerbation. Someone have a COPD, they come in the emergency with exacerbation. So when you ask them, have you ever had it before? And they say yes, and then you ask them and you already know the diagnosis, right? Instead of like asking 50 questions and then finally know that they are having a heart failure exacerbation here, you kind of very first line, you figure it out that they may be having an exacerbation. Okay. Onset, setting, course, frequency, duration, for how long, you already know it's 1.5 hours. After onset, setting, course, frequency, duration, if it's a pain, it's always PQRST. Tell me exactly where you're having the pain. And to work out, when I'm saying all this, you will figure out the questions that you missed during your history, right? So tell me the position. So they will tell you the position on the left side. How would you describe it? So you can see that I'm asking open-ended question. How would you describe it? Well, it's pressure-like or anything. Or sometimes if they can't come up with anything, then you can add a close-ended question. Is it like pressure-like or like stabbing or like sharp? How do you describe? Right? So second question is always close-ended. First is like, how would you describe it? Does it shoot anywhere at all? So I'm not saying, is it going to your left jaw or like your left shoulder? Does it shoot anywhere? Open-ended question. Okay. On a scale of 1 to 10, how bad is it? So just simplify your life, right? On a scale of 1 to 10, how bad is it? And then they will tell you something. And then, have you noticed any trigger of, and in this case, you know that they were helping the son and the exertion kind of brought up the pain. But sometimes if you don't know the trigger, you can ask here. Or if anything where timing is important here, you can ask them that any time association. After PQRST, now it's the time for associated symptoms. That along with this chest pain, what other symptoms are you experiencing? They may say one or two things, but now if you're thinking of chest pain, based on your differentials, you will ask them, is there any sweating at all? Did you like, are you feeling nauseated? Did you throw up at all? And then you can see that I'm using very common language. I'm not using any medical jargon. Even I'm not saying vomiting. I'm saying, did you throw up? So very, very patient-friendly language, like no medical jargon at all. So nausea, vomit, did you throw up at all? Um, do you feel your heart is racing? So all of these questions. Now, in this case, because you're thinking of ACS and everything, otherwise in certain other things, the associated symptoms will be fever and stuff like that. But here, these are our associated symptoms. And then you will say elevating, aggravating. Is there anything making it worse? Anything making it better? So you can see that this is very, very easy. Onset, setting, course, frequency, duration, PQRST, associated symptoms, elevating, aggravating. Every single history, same way. Now, here you will be asking the differentials. What are your differentials for acute coronary, like chest pain, a sudden acute chest pain? For the differentials, always keep your life threatening at the top that can kill your patient, because you cannot afford to kill your patient. Otherwise, in real life, your license will be gone, but in NACOSCI, you will fail the NACOSCI. It's the safety exam. You do great, but you miss a life-threatening diagnosis and you kill the patient. God forbid you will fail your NACOSCI. So always bring your differentials, the life-threatening one on the top, and then everything else on the. It's like importance-wise, the most life-threatening one, then the serious one, and then the GERD and panic attack and musculoskeletal, because none of them gonna kill your patient, right? So this is how you will be doing. So your life-threatening one, your acute coronary syndrome, pulmonary embolism, aortic dissection, pericarditis, because pericarditis can change to tamponade and that can kill you, right? If pericarditis not gonna kill you alone. So those are your like really tough one, and then you can bring all of other your differentials, like a GERD or a panic attack or a musculoskeletal, all of those things. And then you will be asking questions related to your differentials, because you have to either rule in the differential or rule out the differential. So your first one, acute coronary syndrome. What are the questions or risk factors? So those are if they have any other medical condition, like your high blood pressure, your high blood sugar, your high cholesterol, they all are risk factors. If they are smokers, if they have taken cocaine, these are risk factors. So those are the risk factors that you will be asking for this one. And then for pulmonary embolism, usually you ask the question that if they are having any shortness of breath as well, and if there is any leg swelling, and have they recently was immobilized because for longer hours for any reason, because that covers everything. If they were on a long flight, or if they were like recovering after surgery, or if they had a fracture, any immobilization in the recent time. And then for acute pericarditis, typically the position and everything will tell you this is acute pericarditis, because patient will not be comfortable leaning, like lying flat, and they will be leaning forward. So when you will be asking those questions, that will tell you this is acute pericarditis. And then you ask few questions regarding the, and then you can also ask them if they were sick recently, because viral is the most common cause of acute pericarditis. So after ruling out your differentials, then you can ask the PAM HUG FOS, the last bit of your history, past medical history, um, allergies, medications, over the counter, herbal, ask all of them. And then your previous hospitalization, any urinary changes, any bowel movement changes, how's their sleep, smoking, alcohol, drugs, all of those questions, and family history. Again, family history is very important in certain cases. And then in this one, if you still have time, which you will, when you will practice a lot, then you will have a good history. You will be finishing in 6.5 minutes. So then you can ask them the modifiable risk factors. The modifiable risk factors are your weight, your smoking status, whether you're exercising or not. Those are or control of your medical condition. These are modifiable risk factors that you work on those. You lose weight, you take control of your cholesterol, those kind of things that ultimately health benefits. So those are modifiable risk factors. They are the minor risk factors, but they are modifiable. So that's why they are important, that you can do something about it. Now, this is how you will be taking history of each and everything. You just have to change the chief complaint, but your history will remain same. And of course, you need to know the differentials for each and every chief complaint. Now, this was a case where patient is coming with something called acute, like patient coming with ischemic heart disease, basically. Typical ischemic pain where they were exerting, they developed the chest pain and it's ongoing for 1.5 hours. Because if it was subsided in less than 30 minutes with the rest or with nitroglycerin, by definition, it would have been stable angina, right? But because it didn't, so now it's not stable angina anymore. So it falls into the category of acute coronary syndrome, but we don't know whether it's a STEMI, whether it's non-STEMI, or whether it's unstable angina. Right now, we just know this gentleman, Raymond, is having an ischemic chest pain. So what we are going to do, definitely we gave our differentials, but then the first thing we will always ask for a ECG, cardiac enzymes, and sometimes we ask for a chest x-ray as well. And then we always ask do all the baseline lab work as well, because when they are putting the, like, as soon as the patient arrive in the ED, usually there are two large bore IV lines that immediately, especially the emergency patient, they always put two large bore IV lines immediately in. So when the IV lines are in, they take the blood out. So once the blood is out, no matter, like, you just have to, like, there is one nurse who is taking care of everything, they can send it for everything. So you can send all of your basic lab work, like your CBC with differentials, your electrolytes, your urea creatinine, your lipid profile, your liver enzymes, all of that basic lab work. So this is how you will be explaining to to the examiner that I would like to get an ECG, cardiac enzymes, and a portable chest X-ray stat. I would also like to get some baseline blood work, including CBC with differentials, electrolyte, urea creatinine, liver enzymes, lipid profile, HbA1c. You just get done with it, right? So all of those. And then now they will ask you, how are you going to manage this patient? So remember, always remember your role. They said you're in the emergency department and you're a resident. So when you're in the emergency department, the first thing that you will always do, although these things kind of automatically get done in the emergency, but for OSCE, you have to verbalize it. I will admit the patient and I will immediately admit the patient attached to the cardiac monitor, continuous cardiac monitoring, two large bore IV lines, input-output catheter. I will look at the oxygen saturation. If less than 90, I'll put the patient on oxygen. I will immediately call cardiology, because you're not a referring. Referrer is only when the patient is in the outpatient. When you're in the emergency department, it's a consult. And based on the emergency, it's like a stat consult. And honestly, within 3 minutes, your cardiology team will be in the emergency department. So you immediately consult them, because by now, so this is like very, very urgent kind of things. And then they will show you the ECG, or sometimes they even show you before it, like ECG and cardiac enzymes, and you see ST elevations. And that was right to Verga. It was anterior STEMI, and your cardiac enzymes are high. So this is ST elevation MI. So with ST elevation MI, so the difference that you know between ST elevation MI, non-ST elevation MI, and unstable angina, all of these are ischemic cardiac pain, which simply means that the blood vessels that are supplying to the heart, your coronary vessels, they are narrowed. But the difference is in STEMI, they are completely blocked. So one or more than one vessels has completely blocked. Versus non-STEMI, an unstable angina, they are narrowed, significantly narrowed, that now even at rest, the patient is still having pain, but they are not completely blocked. So what's the difference between the management? When there is a complete blockage, means now wherever the blockage is, beyond that part, your heart is not getting the blood. So your heart muscle is dying. So remember, you read in QE1, time is muscle. So you have to immediately do something to open that block vessel, like urgently. The more you're delaying, the more your muscle is dying or dead, and the more it would remain dead, the less chances of its becoming alive again, right? So that's the emergency there. So you will immediately activate cath lab, and this patient is going for percutaneous intervention, which simply means they will get an angiography, like they will take them to the cath lab, they will take a femoral line or usually take femoral line, they put a dye in, and they will see which vessels are blocked. Is it one block, two block, how many vessels are blocked? And based on that, they will decide, are they going to put the stent, or this is so bad that it's actually need a cabbage. And then they will put the stent. And this is called percutaneous intervention, or when they put a stent, this is called angioplasty, right? So this is where you see ST elevation MI completely blocked. Now, in unstable angina and non-STEMI, we said that the issue is same. Coronary artery vessels got narrowed because of nicotine or a fat or age-related changes, genetic, all of those things. So they are still this much, like maybe this is your regular vessel, and then they become like this much. So now when they are exerting, they will get pain, but when they are resting, the pain subside. Means there is still enough place for the blood in the resting phase. That blood demand is not that much in resting phase. So that is your stable angina. That patient exerting, vessels, coronary vessels are narrow, patient exerting, body increase demand for the blood supply, they have the pain, they stop exerting, the pain subside, this is stable angina. They stop exerting, or they took nitroglycerin, pain not subsiding, this is acute coronary. It could be unstable and STEMI. We discussed STEMI. Now what is non-STEMI and unstable angina? So when you see ST elevation MI, that is ST elevation MI, you said it's a complete block. But when there are no ST elevation MI, or maybe there is ST depression, but the cardiac enzymes are high, that's where you call it non-STEMI. And when ongoing pain for more than 30 minutes, but no ST elevation or depression and no cardiac enzymes, that's where you called it unstable angina. The management of unstable angina and NSTEMI is same. You admit the patient, you give them all that cocktail of ACS, including heparin. The only thing is you have time. You don't need to rush the patient to the cath lab immediately. What is the door to balloon time?
90 minutes.
80 minutes?
90 minutes, yes.
90 minutes.
90 minutes. So you don't have to rush them to get the angioplasty done within 90 minutes. You can do it in next 24 to 48 hours. But what you do, you keep the patient in the cardiac ICU and you monitor them with serial ECG and cardiac enzymes. Every 6 hours, you repeat the ECG and cardiac enzymes. And if patient is clinically stable, means no symptoms, everything is fine, and no ECG changes or no worsening of cardiac enzymes, you still have to do a angiography in this patient to look at the condition of the vessels, but you only buy time. You can do it next 24, 48 hours because the cath lab is busy, so that gives you time. Now, during this monitoring phase, at any point, if patient become clinically unstable, ongoing chest pain, which is not relieving with morphine or all of those cocktail, they become vitally unstable, or there are ECG changes, now it is ST elevation, or anything which is like not normal, then you will just rush them to the PCI, just like you will be rushing a STEMI case. Is it clear, or any questions so far, guys?
Yeah, I think it's clear. Just a quick question. So, for unstable angina, we have 24 hour. No, for non-STEMI, we have 24 hours to do
Yeah,
the.
we can do the PCI within 24 to 48 hours. We do it during the same admission, but we do not rush. It can be, so it doesn't mean that we have to do 24 hours later. It can be next 6 hours, 12 hours, 15 hours. It just means you can do it in next 24 to 48 hours whenever it's like availability, depending on the availability and the logistic of that place. So typically, like when we admit under cardiology, um, it's usually like, especially let's say someone got admitted at 10 p.m. in the night, so then there is no urgency. We don't activate the cath lab, or cath lab is already dealing with all the STEMIs. So we just monitor the patient in the CCU, and next morning, maybe 10 a.m., we get the chance to get this patient down for the cath, then we will do it. So
Okay.
within it, it means this patient need a percutaneous intervention, means angiography within the same admission, but no rush for 90 minutes, right? We have time here, but we will be continuously monitoring them. At any point when they deteriorate, we will just take them. Now, we talk about all this. Where does the door to needle time, the 30 minutes, come, or where does the thrombolytics come?
I think if we are if the PCI cath lab is not available, so then we will proceed with thrombolytic, but first we need to check for the contraindications, such as, for example, recent surgery, active bleeding, any bleeding disorders, pregnancy.
Excellent.
Yeah, and then that one is basically 30 minutes.
Excellent. So always look at the setting. Are you in a suburb? Are you in a remote area? They mention it on your question thing that you're a resident working in a tertiary care hospital. Tertiary care hospital means you have the cath lab, because those are big hospital, right? You're a resident working in a remote area. That means you don't have a cath lab, so you will need to shift the patient. There is no way possible that you can shift the patient immediately, right? So that's where, wherever you are not certain that you will be able to do it. And to be very honest, if you are not clear in your exam, in your NAC OSCE, that where I am, or whether like my patient, if I have enough time to transfer the patient or like do it, you can always verbalize your things, because your concepts are clear. Share it with the examiner. Just tell them that I need to check if the place I'm working at, or the facility I'm working, if it has a cath lab or not. If it has cath lab, my patient is straight away going for a PCI. But if the cath lab is not there, then I need to check how long will it take this to shift the patient to a nearby cath lab. And while making the transfer arrangement, I will thrombolyze my patient after ruling out the contraindication to thrombolytic. So verbalize it, because you're sharing with the exam. What will you be doing in real life? This is exactly you will be doing. So until and unless you're talking it out, the examiner will not find out what you're gonna do. So tell them clearly, this is what I'm going to do, right? So door to needle time, so you know that you cannot do PCI because this is not a facility that he has, then you will be rushing to thrombolyze within 30 minutes to get the maximum benefits. If PCI there, you will be rushing to get the cath lab done within 90 minutes. By 30 minutes and 90 minutes, the landmark, or like the time mark, doesn't mean that we will not do this thing after that. If someone crossed the 90 minutes, that doesn't mean they will not get a PCI. If someone crossed the 30 minute, that doesn't mean they will not get a thrombolytic. These are our mortality benefit. The delay will, as I said, muscle will be dead, right? So these are the standard, or these are the guidelines for the team involved to make sure that this is the rush. We have to do this task within this time period. But even if that time period did not match, that patient will still be getting a PCI. So this is exactly that you will be doing. Now, once you do a stent, then your patient will go on dual antiplatelets for 12 months. So your patient goes on dual antiplatelets for 12 months. And when they are going on antiplatelets, you know that antiplatelets, I mean, these are the medication that can cause bleeding. So actually, you will be counseling your patient. When you will be discharging them, you will be counseling them about a lot of things. Like one, they will be taking certain medications regularly. So all of those, your their diabetic medication, their statin. But along with that, you will also be adding like aspirin or clopidogrel, like dual antiplatelets, and then depending, maybe a beta blocker, ACE inhibitors, all of those medications. So you will tell them that we will be adding all these medication. Uh, they if they noticed any unusual bleeding, like bleeding from the gums, bleeding in their urine, or bleeding in their stool, stop taking their antiplatelets and report it to the doctor immediately, because then that means they're bleeding, right? And then driving after stent placement or heart attack, people are not allowed to drive for certain time period. Now, the driving guidelines are a mess. I don't know like why they make it so complicated. I remember when we did it for our Royal College, we were forgetting it so much that we left it for the just we are like the things that we will revise just a day before Royal College. Driving guidelines were one of those things, because previously it was simple, don't drive for 6 months or don't drive for 1 month, and now they put it so difficult. So you have to check whether their left ejection fraction is more than 40 or less than 40, because if it's more than 40, then they can, if they are private car, they can drive within 1 month. If it's commercial, they can drive within 3 months. If they are ejection fraction is less than 40, then it's like 6 months. It's like a whole mess thing. So what I would say, that instead of trying to attempt to memorize those driving lines, you just say that I will also instruct the patient about the driving, and I will look up the most recent guidelines and print it out and give it to the patient. So anything that you cannot memorize, look it up, print it out, give it to the patient. So you saved yourself. You told the examiner, you know there are driving guidelines. You saved yourself not to memorize all of those, but you said you will print it out and give it to the patients, and the purpose is fulfilled. This is exactly what I wanted to say in Royal College, but for some stupid reason they want us to memorize, which we all forget. Like who keep remembering these things? Um, so, and then of course, ask them to exercise 3 to 5 times a week, 30 to 40 minutes at least. Canadian diet as per the Canadian guidelines. Their blood pressure was high now, but he also said like 140, 145. That kind of also tells us that with diabetic, they shouldn't have 140, 145. So maybe they have undiagnosed hypertension. So you will always say that you will ask the family physician to keep an eye on their blood pressure, because they might need to monitor. And if they are now hypertensive, then need to add another medication to their regime, and then refer them to the cardiac rehab. And before Dr. Varga mentioned echo. She said that I'll do an ECG, and if there are changes, then I'll do an echo to confirm. You don't do an echo to confirm any ECG changes. ECG changes PCI. Before the discharge, you do an echo to look at the structure of the heart. What is the ejection fraction, if the heart is working properly or not, if there is any structural defect in the heart or not, because after all the ischemic insult that happened, maybe one part is not contracting properly, maybe there is a mitral regurgitation. Anything can happen after the heart attack, right? So you will be doing an echo to figure out where they are, because after 6 months, when you will repeat an echo, that will help you see if their ejection fraction has improved in 6 months, whatever was happening, the insult, how much they have improved. So you will do an echo before the discharge, just to make sure their baseline, the new baseline after the heart attack, but you don't confirm anything that is being done on ECG. So this is how you will be doing ACS case. The notes that I shared with you guys, the one I updated and then shared with you guys, so you can see the whole thing of everything that we just discussed, and all the associated symptoms are here to ask. Then, of course, the nearby symptoms, The red flag, if they are related to the case, these are the risk factors. You can see major and then the minor. Some vascular screening, if they have chest pain history, any stroke, weakness, all of those. Then also there is like key differentiating point between ACS-MI, stable angina, pericarditis, GERD, musculoskeletal, PE, panic attack, all of your differentials. Then investigations, all the immediate, additional, and then classification of acute coronary syndrome, and then all the management. So now a lot of the time I get the question that is if the notes are, so this is everything for the ACS and then the next topic. So a lot of the time I get the question if the notes are enough or do we need to study from anything. Now everything that we just discussed, and now you go back to the notes and you see everything is there. Honestly speaking, you don't have to consult any other book then, because you have clarified your concept that this is exactly what is going on, and then you read it from the notes. You don't need to do anything, any other book or anything. If you still confused and something is not clear or some concepts need to be clarified and you're opening up a book for that, you're most welcome. But otherwise, notes should be more than enough for you. Okay. Can we have the note share here, please? Okay, I shared the note in the Telegram group later on, guys, and for the people registered, they already received it. I can share for you guys after the class. Okay, let's move to the oh, seems like someone not in the group. Tipasya, I'll share the link of the group in a bit. Okay, let's do the next case. Okay, Ramsha, are you okay to take the next case?
No, I would prefer someone else to do it, please.
Okay, Mujtaba.
Sure.
Okay, just try, guys. I don't expect you to be the perfect. If you would have been perfect, you wouldn't have been here, right? So, and none of us going to judge you. We all are here for learning. Okay, this is your case, Mujtaba. You have 2 minutes to prepare. There are some labs for you to look at. Once you're ready, I can switch to the
Sure,
lab.
we can go to the lab work.
And if you get scared by seeing so many labs on this one, I'm trying to replicate the original Nakoski. Some of the stations, you will go to the door and there will be a big page to read, and you'll be
Yeah.
like, what the heck?
Right.
You still have some time to prepare. Okay, you can start now.
Okay. Knock, knock. First, I sanitize my hand. I give the sticker to the examiner. Good morning. My name is Dr. Hosseini. I'm the physician on duty in ER today. Can I ask your name, please?
Simon Miller. Can you help
Yes.
me, doctor? Uh, I'm having so much chest pain.
Sure, sure. Simon, sorry, can I address you Simon or Mr.
Yeah,
Miller?
yeah, yeah. Simon is okay. Simon is okay.
Okay, sure. Simon, so we need to ask a few questions to see what's your problem, and then I will help you as soon as I can.
Oh
Is
yeah,
that okay with you?
yeah, yeah, yeah.
Thank you so much. Can I ask how old are you?
I'm 53.
Perfect. Thank you. All right, now tell me about your chest pain. When did it start?
It started this morning. I was having breakfast with my family. It's my wife, my son, and my daughter, and um, I had a little bit argument with my wife, and then I started having this chest pain.
Yeah, okay. No, I know that must be difficult for you. I understand you. Just try to relax, and then we will go through these questions together, and then I will help you, all right?
Yeah, doctor, can you like help me with this chest pain? I every time I come to the emergency, like last year, I came so many time. Every time I come to the emergency, they just send me home. They said you're perfectly fine, but then I'm not fine because I'm having this chest pain.
Right.
Can you like, oh God, I
Sure,
think
I
yeah,
understand that.
I
Sure, sure. That must be frustrating for you, but then definitely I will help you as soon as I can. All right?
yeah.
Perfect. Thank you. Can you please show me where your pain is?
It's just in my chest, like all the left side of my chest.
And does it shoot anywhere?
Um, Not exactly. I just feel like my whole body is so tense and my neck is tense and uh, it was a very bad argument. You know, like my daughter is getting married, and my wife and my family just want to throw a destination party, and my business is not doing great. And um, don't take me wrong, doctor. Don't take me
No,
wrong.
no, not at all.
Yeah,
Right.
it's not like I don't love my daughter. I love my daughter. I love my daughter a lot, but my business is not doing that great, and it's really like I'm willing to pay whatever like here in the city, but I mean, I know my daughter wanted to be a destination wedding for so long, but now unfortunately, and this is what I was like explaining to them, but no one understand
No,
and
I understand. No, I'm sure you're a great father. I'm sure you're a great father, but then these things happen in every family, right?
yeah, and then yeah, I don't know.
No, Simon, so let's go back to your chest pain, and then I will help you, okay?
Yeah, thank you very much.
Perfect.
You know, like last time when I came to the emergency, like I came like 3, 4 times, and they said my heart is doing fine. They did all those tests, and they said your heart is doing fine. And then they sent me to a psychiatrist, and I'm still waiting to see a psychiatrist. Like I didn't even hear back from the psychiatrist.
Yeah, so sorry. No, these things they are really frustrating, and unfortunately, we don't have enough resources for that. Yeah,
Yeah,
so
and
sorry
then
to hear that.
my thyroid, like you can see how my hands start getting like
Yes. Yes, yeah, definitely. Yeah, no, it's obvious that you have this stress. Right. So can you please tell me about your pain? How does it feel like?
Uh, it's just like it's a pressure.
Mhm. And if you want to give me from 1 to 10, and 10 is the worst, what would you give me?
Uh, it's maybe like 4 and 5.
Okay, yeah, okay. So then I'm sorry, but then yeah, I know that it must be difficult for you. Did you
Is there
have any
any
other?
medicine that you can give me and I can feel like better?
Sure, I will give you some medications as soon as I can, all right?
Oh, okay, okay.
We just need to go through a few questions, all right?
Oh, okay, okay.
Perfect. Thank you so much. So, is there anything that makes your pain better or worse?
No, I was so angry. Usually, like, if I take Tylenol or like, um, there was a medication for anxiety that my family doctor gave me because I still waiting to see the psychiatrist. I don't know
Yeah,
where the psychiatrist go. Yeah, so my family doctor gave me some medication and but I forgot to take that. Like I was
it's
just
okay.
messed up.
No, it's okay. I understand that. I understand that. And then last 3 times, 4 times that you came here, or you had this chest pain, what made it better? Do you
Oh,
remember?
nothing. They gave me some medication. I don't remember the name, and they did the test, and they said my ECG, and they said everything is fine, and I don't need a cardiologist, but I need a psychiatrist, and I
Okay.
don't know. I honestly don't know if I need a cardiologist or if I need a psych. I don't care as far
Yeah.
as like someone fix me.
Yeah, yeah, I know. This is really, yeah, this is tough. I know. And did you have any other symptoms, for example, yeah, anything that you experienced with this chest pain this morning?
I just like breathing is hard, but whenever I get anxious, like breathing become hard for me, and uh,
Right. What about heart racing? Did you feel your heart
my heart
racing?
is always racing. My stupid thyroid.
I see. I see. Okay, so now speaking of thyroid, any other medical conditions that you have?
Yeah, the hyperthyroid, and it's keep making me like my hands goes like this, and
Mhm.
um, um, I also like have diabetes, and I'm taking medication for that. I'm taking
Mhm.
a pill for my cholesterol, and I take a pill for my anxiety. I don't know, like, why can't I
Mhm.
remember the name?
So do you take your pills regularly, or sometimes you forget?
No, no, no. I do take. I have this. I put it next to my fridge, and I take it regularly.
Right. And do you smoke, if I may ask?
Yeah, especially like these days, the work is so stressful. So I
Mhm.
was trying to cut off on smoking, so I cut it down to 4 cigarettes a day. But these days, like it's all messed up. I'm doing
Yeah.
a pack a day now.
Yeah, so yeah, remember that actually that's really harmful. So we need to work on that. What about the alcohol? Do you drink alcohol, if it's okay, that I can ask?
Just like socially, maybe a drink over the weekend or once in a while. Nothing excessive.
Any recreational drug do you use?
No, no,
Hmm. And any specific medical condition in your family?
no. Doctor, do you think like this hyperthyroid can give me this chest pain?
So it might, but so based on the questions that we asked, basically we need to do some investigations and some certain lab blood work, and then I will be able to help you. Is that okay?
Yeah, I mean, what else? What other choice I have?
I will help you as soon as I can, I promise.
Okay, okay. Sounds good.
Perfect. Thank you so much. Thank you.
Your time is up as well. So, differentials?
All right. So I understand that this patient has come here 3, 4 times, but still we need to rule out acute coronary syndrome. So so acute coronary syndrome is one of them. The other thing can be panic attack or anxiety. We might also have, I mean, PE, which is not really that likely. Uh, but then for PE and pericarditis, I forgot to ask.
Okay. Uh,
Questions.
the ECG was done in the emergency department. Um, and I actually have it with me. So,
So it seems that there is not really any specific changes. I was just looking for the vital signs. Okay, yeah. So I think the ECG was normal, if I'm not mistaken.
Okay. Um, Perfect. So what will you advise this patient?
So for advice, first of all, the patient needs, I mean, the diabetes is not controlled, so medications for cholesterol, statins, it needs to be on time. Uh, Psychiatry referral and chest X-ray also, and then cardiac enzymes. I'm not sure if it was in the lab that I saw. And then smoking, he needs to stop, as well as exercise, and also some relaxations methods, for example, doing yoga and yeah.
Okay. Um, if you have to rule out that this is not ischemic heart pain, how would you, like, what would be your approach?
So if we don't see any ischemic change and troponin, and then if it's getting better, so this might be stable angina, and then we need to do a stress test for stable angina.
When will you do that?
Uh, we can refer him to cardiologist, but yeah, I'm not sure if it needs to be at the hospital. I mean, at the same visit, or
Okay. And what if the patient is not able to exercise?
we need to do the chemical stimulation. I forgot the reagent though.
Okay, thank you, Mustafa. Good job. Yeah, so this is classic case where you really don't know what's going on with the patient, but you got the message. No matter how hard the patient try to distract you, this is their job. They have been given a script to do that. Your job is to still make sure that you're doing your due diligence, which is still ruling out the life-threatening condition. So the way patient was making it sounds and everything, that it's another anxiety attack. But in last four anxiety attack, this could be MI. We really don't know. So this is the, like, a lot of the time when we kind of put a sticker or a label on a patient, that when they are frequent flyers with some reason, then we are like, okay, this patient is like always having this thing. But the lesson that being healthcare professionals, we are always learning that never dismiss patient concerns. So maybe four time it was anxiety and the fifth time it's an actual MI. We really don't know. And this patient has risk factors as well. He's HbA1c is 8.9. He's like really taking pills for cholesterol as well, smoking and everything, all bad habits. So he still have risk factors. So maybe like this time it's an actual MI. So you really still have to rule out the cardiac causes as well. The distractions were intentional, just to kind of divert your attention and kind of put you back to this thing that, okay, this is anxiety. And the moment you miss to rule out the cardiac stuff, this is something that will go on your score sheet. So it's like, this is how they play with you. They give you cases and they want to make sure that you know your basics, that no matter what, even it seems like a panic attack, even it seems like an anxiety, we still have to rule out the life-threatening condition, the cardiac condition, which can kill the patient, or pulmonary embolism, which can kill the patient. So we still have to rule out all of those. So Mushtaba did a very great job. The patient was very, very distracting, but he was kind of redirecting the patient and bringing him back to the point. So excellent job on that, Mushtaba. You might not be able to take a full thorough history, as patient is, you can see, talkative, distractive, taking here and there. But again, whatever time you get, Mushtaba was doing the right thing, that he was getting back again and again to the chest pain, and picking it up from where he was leaving to make sure he clarify it. Now, in terms of like how you will rule out stable angina, so you don't do it in inpatient. It's an outpatient based on urgency. You can do a semi-urgent or like urgent outpatient cardiac referral for your exercise tolerance test. And if the people are not able to tolerate, you can give them domperidone or anything like, which chemically stimulate the exercise effect. The other thing, patients that he's still waiting to see psychiatrist. So, when you're inside in the hospital, you have all the consulting services. So if you just want to help the patient, maybe you can get them see the psychiatrist, and then that psychiatrist can follow up with them. A lot of the time, these are the things that we do in the emergency department, that if a patient was waiting for so long to see someone and now they are in the hospital and we have the consulting service, we just get that service involved, because once they see them in the hospital, then they kind of follow up with them, and that is a quick, instead of in the community he's waiting 6 more months to see a psychiatrist. Just a little bit of patient things that you can do, and just become like a more caring doctor in an NACOSCI, because the more patient-centered care you're going to provide in the NACOSCI, the better doctor you will be, right? And the better will be the score. Okay, let's move on to the next case. Munira, will you be taking that?
Yeah, I can try.
Okay, let me bring up the case. So as you can see, Munira, you have all 11 minutes to yourself. Means I will be giving you a buzzer at 8 minutes, because that's how it happens in NACOSCI, but you will still continue the rest of the 3 minutes. So nowadays, NACOSCI is becoming like they're giving you more and more cases like this, where you have all the 11 minutes to yourself, but if they ask you to do a history, physical, manage, you have to do everything yourself in that 11 minutes. So the examiner doesn't ask you the post-encounter question, basically. So I'll give you like right now 2 minutes, and then once it starts, the next buzzer will be at the 8 minute. Okay, you can start now.
Knock, knock, knock. I entered the room. I sanitize my hand and give the sticker to the examiner. Hello, my name is Dr. Husna. Good morning. I believe, can you please tell your name and age for me before I start the conversation?
Yes, I'm Daniel Thompson and I'm 32.
Okay. Is it okay if I call you Daniel?
Yes, Daniel is fine.
Okay. Okay, so Daniel, nice to meet you. So what brings you here today?
Well, I'm having some chest pain, doctor.
Okay. Can you please tell me some more about your chest pain?
It's going on since yesterday, but I thought that
Mm-hmm.
maybe Tylenol and some pain medication will help, but it's still there.
Okay. So, can you please tell me, Daniel? I would like to ask you a few questions before I prescribe you some medication because I need to know what is going on here. Is that okay for you, Daniel?
Sounds good.
Yeah. So, can you please tell me, Daniel, how did it start? Was it sudden onset or gradual?
It was gradual. Yesterday I just felt that I'm not feeling. I mean, I wasn't feeling great, but then
Mm-hmm.
around afternoon time I started having this pain.
Okay. Okay. So, is it getting better or worse or the same from the beginning?
It's not getting worse, but it's not getting better either.
Mhm.
It's just
Kind
there,
of the same? Is it constant or on and off like thing?
constant. It's there.
Constant. Okay. Okay. And could you please tell me where is it exactly located?
It's on my left side of my chest.
Can you point out where is it exactly or
No, it's just the left side, here. It's sore.
okay. Okay. And could you please describe how the pain feels like?
It's sharp pain.
Sharp pain. Okay. And anywhere it goes out, like it shoots anywhere else?
No,
Okay. Like going to your jaw or hand?
no.
Okay. Okay. And what about if I would tell you to rate it on a scale of 1 to 10, how would you like to rate the pain?
Around 7.
7. Okay. Yeah, that's a quite a lot of pain. I can understand. Please bear with me for some time so that I can understand better. Okay.
Yeah.
And what about anything? You said Tylenol did not help you, right?
Yeah.
And anything that makes you feel worse, like any position?
I wasn't able to sleep last night, so I
Mm-hmm.
just stayed on my reclining chair, but um,
Mm-hmm. Okay. And what about breathing, deep breath? Does it make
yes,
you
yeah,
okay? Deep breath makes you feel worse, right?
yeah.
Okay. Okay. So, Daniel, I would like to ask you a few more questions. Do you have any flu-like symptoms? Any fever,
Oh,
cough?
yeah. It's going on for it's almost 3 or 4 days now, almost a week.
Okay. Okay. And this is the first time you are having this kind of symptom, or you had this kind of chest pain previously?
No, the chest pain is the first time.
Okay. Okay. So you have flu-like symptoms as well. And do you have any nausea, vomiting,
No,
nausea, or any throwing up? No. Okay. And any sweating?
no,
Okay. Do you have any leg swelling?
no.
Okay. Any shortness of breath?
Uh, a little bit when I exert, but no, not right now.
Okay. Any bloating in your tummy?
No,
Okay. Okay. And you don't have any Swelling in the lower part of your legs as well?
No.
Okay. Okay, Daniel, I will ask you a few more questions. Do you have any weight change recently?
No.
Any fever other than these flu-like symptoms?
No, just this flu, like I had
Okay,
fever with the flu.
okay. So any lumps and bumps in your body?
No.
Okay. And what about any smoking? Do you smoke?
No.
Any alcohol drinking?
No.
Okay. Any recreational drugs do you take?
No.
What about cocaine?
No.
Okay. Okay, Daniel. So I would like to ask you a few more questions regarding your past medical history as I am seeing you for the first time. Is that okay for you?
Yeah.
Do you have any medical condition that I should be aware of?
No.
Okay. So any allergies? Any medication do you take regularly?
No.
And your bowel bladder habit is normal?
Yeah.
Okay. And what about your occupation? What do you do for living?
I work in a factory. It's a clothing factory.
Okay. 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 So what about mm, okay, just just a few moments. Okay. So what about any stress in your life, in your family? Do you live with your parents or your partner?
There's nothing, but you also have to do an examination.
Okay. Okay. So Daniel, is that okay if I do some examinations on you? That will include touching you, looking at you, and listening to you. Is that
Yeah,
okay for you?
that's fine.
Okay. Okay, Daniel, could you please sit comfortably on the couch?
Yeah.
Okay. So my patient Daniel is sitting comfortably in the couch and inspecting from front and from the side. The patient does not have any sweating, does not have any breathing discomfort, and does not look anxious. And this patient is the vitals. May I know the vitals of the patient? Okay, I have the vitals. So temperature is high. Heart rate is 104, that is tachycardia. Blood pressure is normal. Partial saturation of oxygen is also normal. So I would like to inspect. I would like to expose the chest. Is that okay
Mhm.
for you, Daniel?
Yeah, that's fine.
Okay. Okay, I expose the chest
So
properly and I will drop the
your
patient.
8-minute buzzer is done. You have 3 minutes. Yeah. So chest is exposed.
Okay. So I would like to auscultate the patient, all the four cardiac areas. The patient has heart rate is 1 is 2 is normal. There is no gallop rhythm, and
What are
and
you
I will like
what are you trying to auscultate? Is
um,
anything that you're
uh,
expecting?
irregularity in the heart rate,
Heart rate is right.
rate, rate rhythm, um, and uh, and then I would like to auscultate the lungs as well to see if there is any abnormalities in breath sound
Uh,
in the lower part of the
clear,
lungs.
clear breath sounds bilaterally.
Okay. And is there any crepitations?
No.
Okay. So I am ruling out the heart failure. Then I would like to see the edema, bipedal edema,
Uh, there is no edema.
and I'd like to also see the pulse, if there is any rate rhythm changes. And, mm, so-
If you're done with the exam, you can proceed with management.
okay. Yeah. So on management of this patient, I would like to give the patient okay, this patient is taking the antibiotics.
There
So,
are some lab work back that you can have a look at.
okay. Mm. So ESR is high, CRP is high.
And your time is
Hemoglobin is normal.
up. Okay,
Okay.
so good try, Manira. I know first class.
But yeah, I forgot about the examination at all.
Yeah, Amber is asking, can we write notes while taking history? Of course, absolutely. You can write notes. Actually, MCC will give you a small, thin booklet that they will give you, and then they will take it back towards the end of the exam, but they will just discard it. They don't even bother to look at it. It's not included into your score. So feel free to write anything in that. And usually, what I ask my student, like every, even when you're preparing with your study partners, make a habit of like when you have like 2 minutes, and even in the class. So for example, Munira is presenting, so she's preparing the case, or previous to that Mushtaba was preparing. You all should be ideally preparing the case, so you read the stem quickly. So how I used to do it, like if I have I'll show you my paper. So I used to like, if this is the sheet I have, I used to make a box here and just put DD. And I put my differentials on this side and put it in a box. So kind of like, you know, that these are your differentials. And then if I have time, I will quickly do the same thing. OSCFT, PQRST, associated, A, risk, DD, PAM hug force. A quick. So it take like 20 seconds to write off all of this, but it's like a quick brain exercise. And especially when you're preparing it right now in the class, or when you're preparing with your study partner, you will write it so many times. It's like your practice and your memorization. So every time you're looking at a chief complaint, so for example, you just looked at chest pain, right? So this was the third case of chest pain, and you're writing the differentials every single time when you're seeing the chest pain with me in the class, then with your study partner. So imagine how many time you're writing it, how many time your mind is memorizing it. So it's like, instead of just listening to the class, do active preparation with us. So you, when whoever is presenting, doesn't matter, everyone should be focusing on preparing the case themselves. So when you have that 2 minutes, when your co-presenter who is presenting is preparing, you're preparing as well, and then listen to them and figure out what they have missed, which you would have asked. So this is how you do that active learning there. So you have your differentials. In fact, I also write, let's say it was 34M Daniel Thompson. So I quickly write 34M Daniel Thompson, and ER or clinic, whatever was my setting. And then I do OSCFD, PQRST, associated AA, RF, DD, PAM hug force. Differential first of all here. The reason this one, in case you under exams pressure you forget the name, you can quickly look at the name. You will have the age there, and you will have the setting. So now if you have to send the your setting is clinic, and you kind of figure out, oh, this patient need to go to ER, so then you can mention it in your management plan. So this is how prepare it. Now, this was case 11 minute, and you can see that I was like in between giving some prompt to Manira. I'm like, you, if you're done with history, you can move on to the examination, or then if you're done with examination, you can tell me the management. In real exam, this is not gonna happen. If they have given you 11 minutes and your task is clearly, they said, you have 11 minutes to take a focused history, do a physical examination, and discuss your management with the patient. And then the only buzzer will be, of course, once you enter the room, one at 8 minute, and then one where at 11 minute where you have to leave the room. So in between that 11 minute, you have to manage your own time. So you have, as soon as you're done with history, and you can see that the history was straightforward, and you don't have to ask everything in the world. Like right now, Munira was done with questions. She's like, I don't know what else to ask, and she started asking me parents and stress, and I don't know what else. And I'm like, if you're done, just go ahead with the examination. So you're done with the history. You're done with the history. You start taking your doing your examination. As soon as you're done with examination, your 8 minute buzzer was done already when you started examination. So quickly finish the examination and move on to the management, because once 11-minute buzzer, you're out of the room. You cannot do anything with this station. This station could be challenging, as you can see that you have to manage your own time. For example, if it was an 8 minute buzzer done, now examiner will ask you questions and your whole post encounter is saved. Here the risk is, because you have to manage your time and you forget about it, 11 minutes, you're out of the room, you left your station incomplete, and that will result in a compromised Nagasaki score, right? So practice with your study partners these 11-minute stations, because for some reasons, they start loving these 11-minute station where you do everything. It's like examiner is just resting, chilling, and you do everything yourself. So now this was a case of acute pericarditis. Munira, I don't know what were you struggling with the ECG. So with the ECG, guys, just like, there are only, I think, seven, six or seven. I'll tell you, like I'll write it in the group, the 6, 7, 8 ECGs that you have to prepare. Just those one. Typical ECGs that you will get to see. Here it's like widespread ST elevation. Look at this. Everywhere you look in any lead and there is ST elevation. So whenever you see the widespread ST elevation, this is acute pericarditis. So you already took the history, which was very consistent. Patient having it's a young male which have nothing else, just a flu, and then having a chest pain, which was worse because he couldn't sleep last night. He sat on the chair, so better on leaning forward. Typical tip, and pleuritic chest pain, like get worse and take deep breath, and sharp pain. So you know this is this one, but you did a good job on ruling out other differentials. You can still, like when they say what are your differentials, you will be giving them in your like acute pericarditis, pulmonary embolism, pneumonia, acute coronary syndrome, all of those still in your differential, but it's a straightforward acute pericarditis, right? With acute pericarditis, the other thing is, what is the cause of this? Most common is the viral, but then you know that any other thing, anyone having an autoimmune condition, rheumatoid, TB, end-stage kidney disease, uremic pericarditis. So just ask those risk factors that what kind of. So this was a healthy young adult which has nothing else going on. So this is like acute pericarditis, which is most likely viral. For our Royal College, for some reason, they love uremic pericarditis, because then the management is always dialysis as well. Because here, you just give them NSAIDs, which is the mainstay of treatment, and then to prevent the reoccurrence, you give them colchicine. You don't give them steroids routinely, but if they are not getting better, you can give them a short course of steroid as well, but mostly like it's NSAIDs. But most importantly, do not forget to educate your patient, because most likely you're not going to admit this patient. You will give them NSAIDs, maybe colchicine, discharge them. But remember, in the beginning, I said, yeah, pericarditis may not kill you, but tamponade can kill you very quickly. So pericarditis is basically, so pericardium is the membrane that is covering the heart. So inflammation of that membrane is pericarditis. So because of that inflammation, everything is leaky there. So if there is leakage of fluid and everything, there can be development of tamponade, which simply means fluid around the heart. So now if there is a lot of fluid around the heart in a closed sac, you can see how quickly, like, this fluid is going to exert pressure on the heart, right? And can cause arrhythmias, can cause all those kind of disturbances, and can kill you very rapidly. So your patient pericarditis, just the NSAID, but then when you're discharging them, you will tell them that you're at a risk, like risk of developing, or there could be a complication where you, because of this inflammation, you can accumulate fluid around the heart. And what does it mean to you? It means to you that if your symptoms are not improving, or if your symptoms are getting worse, or if you develop any new symptoms, please immediately come back to the ER. So this is exactly what you will be teaching them, because if you're discharging them without these teaching points, and God forbid something happens, again, real life, your license gone, but Nakoski, your station gone. So don't do this. So whatever is important in the, whenever you're discharging a patient, do not forget to teach them about the red flag and when to come back to the ER. So in this case, this will be like, these are your red, and this is everything. Like, there's simple concussion, you have to teach the patient red flags and when they have to come back to the ER, right? So patient education is extremely important. When we discharge patient from the ED without admitting them, means just ER visit and we discharge them, it's actually a very high stake discharge, because we get confused. We are like, oh, are we sure we are discharging this patient? And then once we are like, we objectively like looking at all the numbers, labs, everything, and we are like, okay, we can safely discharge this patient. But then we teach them and we make sure that we put everything in their discharge summary. This is everything protecting us and protecting patient. Protecting patient in the sense that patient is our responsibility. We don't want our patient to die because of something which could have been preventable, right? And then documenting everything to protect ourselves, that what if the patient tomorrow says that, no, they didn't even tell me to come back to the ER. So you put that in their discharge summary. So the document that goes with them, that no, we did our job. We did educate them that they have to come back. So this is how you will be doing a case of acute pericarditis. Nadeem asked, patient has fever, why we won't give antibiotics? So for the fever is because of the inflammation of like pericarditis or the flu and everything. So antibiotics in the pericarditis is not like evidence-based. It's just the NSAIDs is more than enough to settle down that inflammation. But that's a good question. Ask any question, because questions are important to make your concepts clear. So now you can see one chest pain, but so many different things that can come. Oh, examination point of view. What I wanted you, so whenever there is an examination with a history, it's a focused or relevant examination. You don't have to examine everything. So what is important from pericarditis point of view? I really want to see if there is a pericardial rub, because friction rub, that's a very, very common exam finding that you will find on exam, right? So pericardial friction rub, and you will look for the JVP. And the third thing, just to look at the edema. So basically auscultate, you can even palpate for the friction rub and auscultate friction rub, and examine the JVP, and then just a very quick looking at the pedal edema, or if you want to palpate calf just to rule out pulmonary embolism, those kind of
So,
things.
Dr. Samina, for JBPs, do I need to tell the patient to stay like uh, 45-degree angle?
So do know how to examine JVP in exam. So everything, examinations are easy. You just have to do them, like memorize them and do. So, for example, in JVP, yes, put the patient on 45 angle. Usually they are on the stretcher and you will be able to put them or just put a pillow and put them at a 45 angle. Always like definitely you will turn and then they will ask you, where are you looking? I'm looking between the two head of sternocleidomastoid because they want to know where you're just looking at the neck or where you're looking. So I'm looking at the between the two head of sternocleidomastoid. And then sometimes they ask you, how will you know this is like it's a venous pressure and not arterial pressure. So like when it's get prominent with inspiration, so taking a deep breath, or hepatojugular reflex where you press on the liver and then you will see the engorged veins. So basically know your JVP, that how to examine it, and also know that what are the some of the things where you can make sure. For example, you want to know that this is actually JVP jugular and not the carotid, so you can palpate the opposite carotid at the same time when you're looking at the jugular. So all there are 3 to 4 things that you typically do to make sure that this is actually jugular and it's not the pulse that we are seeing is not carotid, it's jugular. So you always look between the two head of sternocleidomastoid. You palpate the other side of the carotid. You ask the patient take deep breath and look at the vein. You do the press the liver and look at the vein. So just like make sure that you guys read about those and know about this. And friction rub is
Do we need to just verbalize that I am going to keep a pressure for hepatojugular reflex, or we will just do it?
you will be doing it. If they are asking you
Okay.
to do the examination, you will usually you won't be doing all of this until and unless it's a JVP station itself. So for pericarditis, you won't be doing it, especially if you don't have time. Don't do all of this. It's just like I'm preparing you for the exam, right? So it's my duty to tell you what are the things that are high yield that you need to prepare for the exam. So make sure that
So
you
if I don't have time, just if I tell that I
just the
am just
JVP, high or
JVP.
not
Okay.
high. That's it.
Mhm.
That's it.
Okay.
Don't even like sometimes they ask you that it's a follow-up question where they ask you how you will ensure that this is JVP. So then you need to know that
Okay.
what are the things because in even in a physical exam station, they can ask you a follow-up question. So for whenever it's a JVP, these are the follow-up questions that how you will ensure that this is a jugular and not a carotid pulse there. So I just want to make sure you know what you have to prepare for the exam. Okay, next, let's move to the next one. Do we have Caroline in the class? The cameras got automatically switched off. We have 30 people in the class minus me, and we have just now some of them, like 4 people are consistent. Um, Cindy, you just switch on your camera, so I think you can go ahead with the case.
If it's okay, I would like to do it next time. I'm not confident enough.
Okay, that's totally fine. And even if you're not ready, like as you know, we are here for learning. You guys are doing it way better than I must have done as when I was preparing for my NACOSCI first class. I'm sure I was way worse than this. So we all, if I'm talking so much today and like acting so cool, it's like years of training there. I'm done with my 3 years of core internal where this was my bread and butter. So don't get impressed from me. This is like years of training there. When I started my NACOSCI, I'm sure I was worse what you guys are doing in the first class. I'm sure I was not even close to this in my first class. So we all prepare. There is a starting point for all of us, and that's where we start, and then we slowly develop on that. So it's not important how you're preparing today, like presenting today. It's just getting you into this habit of speaking up in the class. That's it. Um, Practice with your study partners as well. And you will see, you guys have a lot of time. Like we are starting early. It's mid-December and exam is in May. So this is the benefit that we have, that we have a lot of time. I just wanted to cover so much today, so I didn't talk about how to study, how to make study groups and everything. I will be talking about this to you guys later on, that how to prepare your study group and how to prepare, how to study, what to cover in a week time. But you guys have a lot of time, and you guys will see how much improve you will be towards the end of the course, and expert and great, and then you will just rock and roll. Okay, I think Ramsha
Dr. Savina, I have a question before you move on. So for the management of the
asked
patient of
a
acute
question. Sorry.
pericarditis,
Oh, Manira, yeah, go ahead.
yeah. So for the management of the patient for acute pericarditis, how long we need the patient to educate for taking rest?
For taking rest, usually it's like as soon as their chest pain subsides and they start feeling better, usually it's take a week time until all the symptoms get resolved.
Okay.
Ramsha, you're ready to present?
Oh no, I just had a question.
Okay, go ahead.
Can you elaborate a bit more on how to break our 11 minutes? Like we have to do the whole thing in 11 minutes. So
Okay.
how much do we give to history and all?
So any history and physical, so you will be getting so this there are two, three different kind of formats in NACOSP. So one is 8-minute history only 8 minute, and then there is a buzzer and 3-minute post encounter with the examiner. Then you can have a station, 8-minute history and physical, and then a buzzer and 3-minute post encounter with the examiner. And then you have this 11-minute where you have history, sometime history only, sometime history and physical, sometime counseling, and all 11 minutes to yourself. So it doesn't matter if it's like a buzzer at 8 minute with the examiner or not. The thing is that when it's a history, as soon as you read that it's a history and physical, both that you have to do, you have basically 8 minute, because the rest of the 3 minutes that you still have, you will be talking about management and discussing with the patient. So in 8-minute history and physical, ideally, I would say 4-minute history, 4-minute examination. The reason is uh, examination, you will be practicing a lot for the examination as well, and it's easy. And again, the videos that I send you, just watch those, perfect your examination technique. Even if you don't have a study partner in person, doesn't matter, your pillow is your study partner. So basically this is just mastering the skills. So you're like, well, Mr. Pillow, now I'm going to examine you. That means I'm going to palpate you, like I'm going to touch you, feel you, and maybe listen to your heart or lung. Is that okay? So you're talking to Mr. Pillow because you're just practicing yourself. You just have to memorize the script, right? Is that okay? And Mr. Pillow said, that's okay, go ahead. And you will be like, my patient is sitting uncomfortably. I can see that the patient is leaning forward and a little bit of out of breath. I will now proceed with cardiac examination, and for that I need to expose the for that, Mr. Pillow, I will be exposing your chest, and meanwhile I'll drape the patient. So you take the sheet will be on the stretcher. Take the sheet and just put it on their lap if they are if they are sitting, but if they are lying down, then just below the navel, and you just expose their chest. Draping is extremely important. There will be a sheet, look for that, and if you don't find a sheet, ask the examiner where is the sheet because they want you to make sure that you're draping the patient. It's like one of the many things that get tested in the examination, right? So you drape the Mr. Pillow, and then you look at the chest and you're inspecting Mr. Pillow's chest, and you're verbalizing, I'm looking at the chest, and whatever you're looking for, right? So basically what I'm trying to say, that you don't need anyone to practice and memorize your examination skills. Watch the video, learn the skills, practice it on Mr. Pillow. You feel like you're still like not getting it, go back, watch the video again, and then practice again. If your husband, or if your children, or if your sister or brother or parents or whoever is willing to be your object or subject, take them and practice on them. And this is how you will be learning your physical examination skills. So when you will be doing physical examination, it's a spontaneous, it's two three things happening together. You're doing physical stuff and you're verbalizing it. So I mean, this looks so silly that you're doing all this stuff and at the same time you have to verbalize it, but you have to verbalize it because the real patient, they won't give you the real patient, they will give you the standardized patient. The real patient will have the finding. You will put a stat there and you will listen a pericardial rub, but Mr. Pillow won't have it, or in your exam whoever mister there, they won't have pericardial rub. Now if you're just listening and not saying anything, that's it, examiner will not say anything, but you're like, I'm auscultating and I'm trying to listen to or trying to auscultate pericardial friction rub, and the examiner will say present, so they will give you the finding. I'm looking at the patient JVP and I want to see if the JVP is raised or not. The patient you will be looking at, it will not be raised. Examiner will say JVP is raised. So that's why it's it's technical that you have to verbalize and do the things at the same time. So you really need 4 minutes, if not more than that. So 4 minute history, 4 minute physical exam. Claudina, you have a question?
Yes, good evening, everyone. Thank you so much, doctor, for this class. It is the first time that I joined, but you mentioned that the videos that I sent, is this like, what is this? I just joined because a friend sent me the link, and I'm like, oh, okay, but I don't know. It's my first night. I want to participate in a case, but I want to know, like, what is this
Yeah.
about? Like, how is it? Yeah.
So, Claudina, this is my first class of my regular course, and there are a lot of people among you who are registered for the course. So basically, they registered, so they got the notes and they got the stuff to prepare for the class and everything. But definitely, the guys who are watching it as a demo class, they don't have access to that as of now. But if you
Mm.
guys, any one of you decide to continue, then for sure you will be getting all that material as well. The reason I invited you guys to attend this class instead of conducting another demo class, because as I told you guys, I'm doing my fellowship and my days and nights are quite busy. So I didn't have a time to do another demo. So I decided I'll just take you guys in my first class. And I feel like demo is usually an hour long that don't give you a real picture of what the class look like. This will actually give you that this is exactly how the class look like. Any one of you who is interested to continue with the course, just reach out to me after the class. Our next class is next Monday, so we have a lot of time in between. Okay. Caroline, your camera is not, okay, audio is also not working. Okay, no problem. So let me see then who we have. Do we have Hanif in the class? I think Hanif said he is, mm, I think he said he's working. Um, Firdos, do we have Firdos in the class?
Hi, I actually couldn't change my name in the
Then be you.
sorry.
You're
It's my
hiding
last
here.
name.
Okay.
Is my last name, yeah.
So let's try a case with you. You don't need to be perfect, okay?
Sure. Okay. Yeah.
You're getting an easy case.
Okay.
So basically, you have all 11 minutes to yourself, Firoz, and it seems like it's a counseling case. So go ahead and try your best. You don't need to be perfect. Okay, you can start now. I will give you a buzzer at 8 minutes, because that's how the neck OSCE is. There is always a buzzer at 8 minutes. If it's a history and physical, you have to stop there. But if it's like a counseling, that just take it as a warning sign that you have 3 minutes left to start wrapping up the stuff. Okay, go ahead.
Okay, knock knock. I will sanitize my hand. I will enter the room and give the stickers to the examiner, and I will just introduce myself. Hello, I'm Dr. Nadima. I am here. I will be your physician today.
Hi.
I will just. Hi, I just wanted to know like what brings you here today. Oh, before actually we start, can I confirm your name and your age, please?
Yeah, I'm Athur Key. You can call me Athur, and I am 34.
Oh, okay. Hi, Arthur. So again, I'm Dr. Nadima. So what brings you here today?
Oh, well, it's my chest, doctor. It's bothering me for quite some time now.
Oh, so is it like you are having chest pain?
Yes,
Oh, okay. I'm sorry to hear about that. Let me see what I can do. Like, I will just ask you a couple of questions. But before I start, I will just assure you, like, everything we will talk, it will be confidential. So, like, feel free to share anything with me.
sure,
And if you feel uncomfortable or any problem, just let me know. I will look what we can do.
sure.
Um, yeah. Okay. And I was just wondering, like when, like you said, like you are having chest pain, like when did it start?
Well, I'm having this chest pain for almost 2 months now. Yeah, for on and off 2 months now.
Okay. And you said like on and off, like is it like how do you describe the like on and off thing?
I mean, I don't have it always, but then
Mhm.
some days, like sometime I may get it every day, sometimes maybe like 3 to 4 times a week. So it's not like something always there, but I do get it quite often.
Oh, okay. So you will say like it's like coming, how many times in a day it may come, or can you like
Uh, yeah, I mean, usually I get it around maybe like around midday or like around 2 to 3 p.m. and then I'll constantly have it, and then I just come home and I'll eat, and sometimes I take some medicine and it will help me. Um, it's that's like a typical thing. Sometimes I'll get lucky and I'll not have it at all.
Mm-hmm. Okay. And this pain, so and you said like how long usually it stays, like the pain when it starts?
It varies, like maybe couple of hours, like 2, 3 hours.
2, 3 hours.
Sometimes if I take medicine early on, an hour. Sometimes I get it at night as well. So there's no like pattern, to be honest. Like it can varies.
Oh, okay. And can you explain more about the position, like where is your pain?
The pain is like it's in the center of my chest, like.
Okay. Okay. And does it go to anywhere? Like, does it go to up or like or left or right? No, it just stays in one side, in the central part.
Yeah.
Okay. And can you like describe about the pain? Like, is it like squeezing kind of pain or like stabbing or sharp? What kind of pain is it?
It's more like burning.
Burning. Okay. Okay. And um, and can you and you say can you tell me like on a like when the pain starts usually? So can you tell me like on a scale of 0 to 10, like 0 being no pain and 10 is the worst, like what would you rate your pain when the pain starts?
It's like around 5 to 6.
Okay. And uh, do you feel any kind of triggers this kind of pain? For example, like if you eat after eating, or like if you lay down, or like any kind of triggers?
Yeah, maybe like sometimes, like, when I'm lying down, I get this really bitter taste water in my mouth.
Okay.
Yeah.
Okay. And does it like is there anything like alleviate those kind of pain? Like does it make anything better?
I got Tums from the market, and sometimes that helps.
Oh, okay. The Tums, right?
Yeah.
Yeah. Oh, okay, okay. And does it and you said like when you lay down or like sometimes when you eat and then you feel that kind of pain coming back.
Yeah, I mean, it's like sometimes I get it like when I'm not eating, like
Okay.
with empty stomach, but sometimes I get it after eating as well. So it totally depends, like what is the bad day.
Oh, okay. Um, and do you feel any kind of nausea or vomiting when you feel that kind of pain or any kind of
It's just like this burning pain, and yeah, it's the burning it and that
burning feeling?
taste in my mouth. Yeah.
Okay. And can you tell me more about about your some kind of like social history? For example, do you smoke
Oh yeah, like a pack a day.
like a pack a day? Okay. And how about do you drink?
Mm-hmm. No, I'm not a regular drinker, but over the weekend, a glass of wine.
Oh, okay. And how about any kind of drugs?
No, no, no.
Uh,
I don't do drugs.
Recreational drugs? Don't. Okay. And can you describe more about your eating habits, if that's okay with you? Like, for example, like what kind of food you
Yeah.
usually like, or yeah.
So I work, so I'm not a breakfast person, so I don't take breakfast. Usually I don't carry lunch either, so I don't eat lunch. But then I come home like around between 4 to 5 p.m., and that's where I usually have my supper, and that's my one big meal. And my girlfriend, she makes really, really yummy food, so she I actually gained weight since I got into this relationship. So yeah, she makes yummy food, and I like all those, like cheese and meat and
Oh,
pizzas and all those kind of stuff. And she really makes yummy food.
oh, that's really nice. That's good to hear. I was just wondering more about like the timing, like what time you said like 4 or 5 o'clock you
Yeah,
eat
so
your
usually I
big
take one
yeah.
meal because I don't want to, like, I gain like 4 or 5 kg, as I told you, since I got into this
Yeah.
relationship.
Mm-hmm.
So I don't want to get so I'm intentionally trying not to get too much like overweight. So I'm
Oh,
just
okay.
taking one time a day.
How about do you feel like when you swallow, do you feel any pain in your throat or
No,
no? Okay. And how about did your girlfriend notice any kind of changes when you sleep? For example, you snore or like any kind of sound you make?
no. That's your 8-minute buzzer. 3 minutes to go. No, she didn't notice anything.
So I was just I feel like after talking with your eating habits and seeing thing, I will just uh, say you may have some kind of GERD, that means like gastroesophageal reflux disease. So sometimes like this is one of my diagnosis, but I would definitely rule out the other serious uh, issues for your chest pain. But for like taking all of your histories and other things, I find it's like more like GERD. So for GERD, what happened is like when you eat a lot of meat product or dairy kind of product, and you take a big break and then suddenly take a very large meal, sometimes the acid reflux and gastric pain happens. So that's why like it feels like burning sensation to your throat and other areas. And also you recently gained some weight, which also can maybe the cause for your GERD syndrome. So I would suggest like if you wanted to I would definitely check all of your labs and investigations and rule out after ruling out other things, I would uh, suggest for you to change some of your lifestyle so that in future it will help you. For example, for smoking cessation is very important because smoking is another main cause for having
God,
GERD. So
I was
what are
really
your
not
thoughts?
gonna say this.
So what are your thoughts about cessation of smoking?
I mean, if I have to, I was just hoping and praying silently that the doctor forget about it. But yeah, I mean, I'll try to cut it down.
Yeah, that's really good to hear. That's the first step. So very good. And how about the other things also we will talk about. Uh, Actually, I forgot to ask about your medication history. Do you take any kind of medication other than like you said like you can take some of the pain medication, right?
Just the Tums. I don't take anything else. Like sometimes, like when I have back pain after sitting for long in the office, I take the Brufen.
Ibuprofen. And yeah, I heard like you said like you don't eat for the whole day and you take a painkiller in empty stomach that might also cause your gut problem. So I would suggest like take a little bit of food before, if you want to take the painkiller, take a little bit of food before you take the medication, and also the lifestyle modification, do some healthy food practice too, not
Your,
incorporate some
your
vegetables or fruits.
time is
And
up, but one question, doctor. Will you be doing the camera test for me?
we can do the camera test, yes, because we have to rule out that your if you have any kind of issues inside your yeah, we will definitely do uh, the gas.
Camera
I
test.
forgot.
Okay. Thank you, Feroza. See, it wasn't that hard. You just have to try. So good job. I mean, for the first class guys, it's just the try. I usually start getting hard after fourth or fifth class. That's where my expectations start going up. In the first class, I'm very chill, so take the advantage of presenting in the first class. Okay. Joke apart, when your patient is a happy patient, they are just lovely, they have smiles and everything, feel free to replicate the same expressions. So if you go to a family physician or anywhere and you're smiley, they smile as well. So it's not like they are always those angry faces, monsters that are just looking at you that they'll just eat you alive. So family doctors or doctors in general can be nice people, right? So any of these stations where it's a chill station and there is some the patient looks like chill and smiling, just smile and have that same kind of nicely professionally friendly relationship. So you did get along with the patient, so that was good. In the beginning you were scared of the patient, but I think then slowly patient was able to get you along. So yes, you can totally smile with the patient. You can, if they are throwing a little bit jokes here and there, you can always throw a little bit jokes there, just keeping the professional boundaries intact. Now, just for the counseling stations, the purpose of the station is to see how are you going to educate the patient. You did a reasonable job for the first class, Feroza, but the whole purpose is like how you're going to do. So again, don't take a very, very long history where you spend all 11 minutes just taking the history. History should again be just very brief. So there are two type of counseling, the way you can do it, either conversational counseling that you're talking to them, asking some questions and then teaching on the spot, or you're not comfortable with that, so you take a very good quick 4 to 5 minute history and then remaining time you just counsel them. There is no right and wrong. Both way are fine. It's just you have to find your own comfort, that which way you're comfortable with. You will be practicing with your study partner. You can practice both way, doing a history and then consult. So for example, now when you will go back, go and practice this case with your study partner. One time ask them to present, one time you present it. So do it twice. So you can present one time like just take a history and then all the counseling, or you did little bit teaching, question, teaching, question, teaching. So, and slowly figure out what is your style. So when Athur came in, um, one other thing for the teaching point of view, in the beginning, don't do those long sentences. Hi, my name is Dr. Nadeem. I'm the physician on call. I will be asking you a few questions because that's a long introduction, right? And the patient is just looking at like, so it's like, hey, is this Athur? Yes, I'm. Hi, Athur. This is Dr. Khan. How are you doing today? So you started talking. Oh, I'm good, doctor. Thank you. So tell me, Athur, how can I help you? Well, I'm having this chest pain. It's my chest. Okay, tell me more about it. I'm having this chest pain for the last 2 months. Okay. And is it constant since then? No, it's on and off. Okay, so tell me in detail, how often do you get it? And then he start describing his pain. How long does it stay? Have you seen a doctor? What do you do to relieve it? Just take terms, haven't seen a doctor yet. You're the first one I'm seeing. Okay, great. Is this the first time you're having this pain? Have you ever had it in the past as well? Well, I used to get it when I was in university, but then it subsided, but now I'm having it again. Okay. And when you had it back in the university, did anyone tell you what kind of pain was it? Well, they said I had stomach acidity or something. There was at a point they were even planning to do a camera test, but then they never did it because the pain disappeared. Okay, great. Did you ever use, like, did anyone ever tell you you have a bacteria in your stomach? No, I haven't heard about it. Did you any time use any antibiotic to kind of take care of any bacteria in your stomach? Again, not ringing any bell to me. Okay, good. Just want to make sure that I get all the accurate information. So basically, what I was trying to do, I was figuring out he has a GERD history, whether he had an endoscopy, whether he had a H. pylori testing priorly, and whether he got treated for it or not. So all the important information. Okay. So the pain that you're having, Athur, how does it feel like? Well, it's burning. Okay. Does it come any specific time of the day? What is its relationship to the food? So open-ended question, and he's giving me all the information. Okay. So I will not ask all the history question. This is how you ask all the questions. And then once you're done, you're like, thank you very much, Athur, for providing me with all this useful information that made my mind very clear. And I think I kind of figure out what is going on, although I will still be doing a full physical examination on you, conduct some lab tests to make sure that we are not missing on something important. But what I think that you are having is something called gastroesophageal reflux disease. Have you ever heard of this? So now you see that how you that well, I think you have this, but we will still be doing a full physical examination, sending some blood, some lab work, making sure we are not missing on anything important. But what I think you have gastroesophageal reflux disease. Have you ever heard of this? Because you want to know what is patient understanding and build on that. No, I never heard of it. Patient can say anything in the exam, right? So have you ever heard of this? And if they say, yes, I think it's like the acidity in the stomach. Yeah, you're right. And then you start explaining. You're right to an extent, and then you start explaining. So what happens, and you have the notebook with you, right? So feel free to draw a stomach, no matter how bad stomach it is. I always draw the things, and then I just seek forgiveness for my bad drawing. So, but what happens that when you draw the things, it makes things easy for patient to understand. And for NACOSCI point of view, the examiner will be like, wow, such a great person drawing and explaining to the patient, right? So draw a stomach, no matter its stomach look like a whole bundle or whatever, and then draw a esophagus on that and show them that sphincter there, right? The gastroesophageal junctions and the sphincter there. So just tell them this is how your food pipe, not esophagus. Your food pipe is connected to your stomach, and there is this sphincter, which is basically the gate between the two, and it remains closed. So basically, when in your stomach, when your food arrive there, there are certain secretions of acids and different things to help in the digestion, right? So this things remains closed so that acid do not come into the food pipe because that it shouldn't be. But because of like different reasons, sometimes like because of like genetic predisposition or like certain risk factors, like people who are smoking or people who are overweight and certain other kind of risk factors, there this gate become loose, and then the acid it just get back into the food pipe, and that's what give you burning. So you explain it to him. Now in the like right now, if you ask me, is it like very dangerous? I will say, well, maybe not dangerous in the terms that it's not gonna kill you immediately, but it's dangerous in the terms that if if your stomach or your esophagus is like exposed to this acid for long duration of time, there is a chance that you can develop cancer. In fact, there is a high risk because your risk of developing cancer significantly increase as compared to the normal population. So that's why it is important to treat it. Now, the treatment is basically a lot of lifestyle modification with a little bit of medication help. So, walk me through your daily eating habits. And now he will tell you blah blah blah. I do this. So, I'm glad. I'm really happy to hear that you got a girlfriend who makes really yummy food. You're lucky. But what I would say, I won't stop you from eating for sure. So little bit jokes there. Like, I won't stop you from eating for sure. Just bring a little bit balance to it. Um, I would say that, I heard that you said you're trying to keep your weight under control. That's why you're eating one big meal and trying to stay hungry throughout the day. While I appreciate that you're trying to control your weight, but at the same time, being a doctor, I would say this is not a healthy lifestyle or a healthy way of losing weight. So, and especially with this problem that you're having right now, it is highly recommended that you have 5 to 6 small meals throughout the day. So basically, you do not let your tummy hungry for too long. So do have a breakfast. It's the most important meal of the day. And then every 2 to 4 hours, have a small snacks. And then even when you're having your meal, it should be a medium meal instead of one large big meal. And then stop eating at least 3 hours before the bed. Don't eat anything 2 to 3 hours before the bed. Um, Again, a balanced diet instead of like eat meat by all means, but then have if your plate is like this round plate, again draw a plate, make them happy. So tell them that if your plate is this round plate, divide it from the center, and then this part divide it into two. This whole thing should be your veggies, and this should be your carb, which is like your rice and all of those stuff like your bread and rice, and this should be your protein, that is your meat. If you divide your plate this way, you're essentially getting always getting a healthy balanced diet, that you're having a very good mix of your your proteins, your carbohydrates, and your fats and vegetables and everything. Um, Another important thing, smoking. Then talk about quitting smoking. And he says, oh, I didn't want you to remember that. You say, and he's like, I'll try to cut down. I'm glad that you're thinking that from cutting down, maybe quitting will be better. And we have a lot of resources available. So I can set up your meeting with the people who can help you with it, and we can do it as a team. You don't have to do it alone. Like there's a lot of resources available, and we can help you with it, right? So this is how like you take one thing and explain them. Now what happens here when Arthur goes home, he will be very clear what he's having, and then you talk about all this, and you can say that I can give you a medication. It's called proton pump inhibitors, pantoprazole and Pentalog. I can give you this medication for 3 months, and then see how things are with you. But remember, this medication is just a small part of the treatment. The overall the majority of the treatment or control is in your hand by making these changes. So he knows that, okay, he can take some medication, but actually these changes are must to overall see the results. And he can explain when he go home, he can explain to his girlfriend that what actually he's having. So any counseling station, they want to see what are your like how good you're at teaching patient, because as a physician we will be teaching a lot to our patient. And trust me, when I say don't use medical jargon, like I got picked up even as a resident when I used anticoagulation, and I came out and it was like 1 hour of teaching, and I came out of the room and my attending is like blood thinners, and I'm like, yeah, thank you. So like even they pick us up as a resident when we use a medical jargon. So now we are so used to that we see the patient and we forget all the medical language. Sorry, I'll take water. When you have flu, you shouldn't be talking this long. Okay. Okay, so this is how you will be doing a good counseling station. So we will be doing a lot of counseling stations in the course. So start practicing with your study partners. So each one of you, when you go back, do this GERD case with your study partners for your own practice and learning. So you learn how to do it. And next time when we do a counseling case, it gets even better. Okay.
So I just have one question.
Sure, go ahead.
So I was just like when I was talking with the patient, I was just saying, "Oh, you are obese, that's why you are having it. Oh, you are smoker, that's why you're having it." Like I was kind of
No, don't even
yeah, like
say like
how do you like you put it very nice way, like in a very like polished way. So
this come with
yeah,
practice. This come with
okay.
practice. So, yeah, even like we don't see your obese and we just say that, well, as you said, Athur, it seems like you said that you gained a couple of pounds, and I mean, I know your girlfriend is cooking really great food. But I can also see that you're health conscious, that you're trying to lose, but how about losing it in a healthy way? So it's all manipulative diplomatic language. It all comes with
Mhm.
practice. As I
Okay.
said, that when you see me speaking, it's years of training and experience. You guys and all this which I'm showing you so you learn from it. Don't get impressed, just learn. Because when you will be practicing, you will even get better than me. So when you will be finishing your residency training one day, you will be an excellent physician having all this. So in Canadian training, they emphasize a lot on communication. So it's one of the, that's why even during NACOSCI, communication is heavily tested. And I keep telling my students that this is one of the most important aspect of the examination, not only for your counseling stations, for your all 10 stations that are going to be marked, your body language, your communication. Trust me, my students who usually get like 3 standard and 2 above the deviation, they are not like excellent in like they did everything right. They make a lot of mistakes, but their overall communications and patient rapport and everything is so great that those things just get overlooked. Like communication matters a lot. So make sure that you guys learn how to do a good communication. Oh, Hafsa reminded me about the camera test, so that's a good point, Hafsa. Good job. Um, Yeah, if the patient asks you, do I need to get a camera test? Basically, they are referring to endoscopy because we don't say endoscopy, we say camera test. He doesn't need it if there are no red flags, and the red flags means if he's losing weight, night sweats, lumps and bumps, means any lymph node swellings, a family history of cancer, any of those things are red flags, then you might just offer him a test. But if he's a healthy 34-year-old with no constitutional red flags, no family history, you can give a trial of pantoprazole with lifestyle modification, and if symptoms resolve, you don't need to do a camera test. Camera test is usually in the setting of some red flags. Otherwise, you don't, just for a simple GERD, you don't do an endoscopy, right? But you can always offer him an H. pylori testing, which is simple, a stool test for the H. pylori. And if that is positive, then you give them the 2 weeks antibiotics to eradicate it. Simple, right? Okay. Now, let's do one more case before the class ends. Oh, sorry, Puneet. Go ahead.
Hi, I have a question. So when we are doing examination, right? So what we usually do is we ask patient, we examine patient, and we just verbalize, "I'm looking for this. I'm looking for this." My question is, do we need to say my patient doesn't have this? Because the thing is, this patient is just a demo patient. It's not a real patient. So we can't just say exactly this patient does not have this finding.
Yeah, so I would say if like patient, for example, sitting comfortably, not showing any signs of distress and all of that, you can say that my patient is sitting comfortably without any obvious discomfort, because at least they can show discomfort in where patient can
Right.
act, right? But otherwise, for example, when auscultating or like, when even doing an organomegaly examination or anything, I usually like don't say that, okay, I'm palpating for the liver and I appreciate none, because then the problem is that they might have a hepatomegaly that they want. So usually I would say that I would like to know um, checking or palpating for like organomegaly or hepatomegaly or splenomegaly, whatever. Or like, for example, I'm now auscultating to listen to the friction, pericardial friction rub, and then just wait for the examiner to give me the finding. Because again, if I'm auscultating, I'm saying none, so then that's not true, because the patient might have it. So I find it this way, that I'm looking for this, so the examiner can say, and they can say whatever. And sometimes even when you say none, they can give you they still give you the findings, because that's how the station is, that's how the examiner is instructed to give you findings.
So the better way would be, we will say, okay, I'm looking for pericardial friction rub, but I'm looking for any abnormal heart sounds.
Yes,
That's
exactly. Just say like this and just say what you're looking for. So, for example, abnormal heart sound, if it's a case where I'm expecting an irregularly irregular heartbeat, for example, or I'm expecting a murmur. So I will say that I'm looking for this, or because, for example, I'm not just auscultating the heart, I'm auscultating to look for the pericardial rub. So basically, the examiner want to hear what you're looking for. What are the thing that you're doing the examination for?
okay. Thank you.
So whether pericardial rub is present or not, you can't say, because the patient is not real, but you have to say that you're checking for the pericardial rub. Okay?
Okay. Thank you.
No problem. Who's going next? Sorry, guys. Maureen, you want to go next? Okay. And I'll take water after giving you the case. You still have 13 seconds, 30 seconds, Maureen. Someone was asking for the link, so I left the links in the chat box for you guys. Okay, you can start now. You're mute. I can't hear you.
Oh, I didn't know I was muted. Sorry. Okay, let me start from the beginning now. Yeah.
Okay.
So, okay. Knock, knock, knock. Enter the room with the examiner. Hand my stick over to the examiner. Sanitize my hand. Hi. My name is Dr. Maureen Eze. I'll be your physician for today. And please, may I confirm your name and age?
I'm David Saylor, and I'm 48.
Okay. How may I address you?
You can call me David.
Okay, David. May I know why you're here today?
I'm having some chest pain.
Oh, so sorry to hear that. So when did it start?
It started maybe like this morning,
Oh, this morning, like how many hours ago? Do you
like
know?
4 or 5 hours ago.
Oh, so sorry. That must be so distressing. Okay, David, since it started, what were you doing when you noticed it?
I wasn't doing anything essentially, just sitting around, and I felt like some uncomfortable chest pain, and I thought it will go away on its own, and I mean that's what usually happens, but it's just constantly bothering me.
Oh, okay. So, since it started, has it been getting worse?
No, not exactly, just the same.
Okay, okay. So, does it come on and go, or is just constant?
No, there is a constant pain.
Okay. Please, can you point to where this pain is for me?
It's the center of my chest on the right side here.
You're on the right side. Okay. Can you tell me can you describe this pain for me? Is it sharp? Is it dull? How is this pain?
Um, it's there is some burning, but there's some sharpness. It's the mix of both.
Okay, so sorry. So on a scale of 1 to 10, okay, 1 being the least pain you've ever had, and 10 being the most, can you quantify it for me?
Somewhere 7.
Okay, somewhere 7. Does anything make it 7? That's a lot. So sorry. Does anything make it better?
Um, Usually when I take Tums, that make my chest pain better, but today I was out of Tums, so I didn't take it immediately when the pain started, and I did take it later on, but it didn't help.
Oh, so sorry. Does anything make it worse?
I'm not doing anything, just like sitting, so I don't know.
Have you had this kind of pain before?
I mean, the chest pain, I get it very often. I'm usually take Tums and it get fine.
Oh, okay. So, okay, but you said it's been a while. It's like you didn't have Tom at home, but you took it later. But did you relieve it when you took it?
I took it like after 2 to 3 hours of pain being started.
Did you relieve the pain?
No.
Oh, okay. Okay. So, I just want to ask you some other questions concerning this chest pain, okay? Do you have like shortness of breath?
Um, Not that much, but a little bit.
When did it start?
Mm, just going on just today.
Okay, just is it same time?
I didn't, I mean,
Notice. Okay. Okay, okay. So this shortness of breath, is it worse when you lie down or is just there?
no, it's just there. I don't
Okay.
know. Do
When
you
you take a deep breath,
think
okay.
if I have an ulcer or anything that's like just a rupture?
What did you say, sorry?
Do you think like sometime I have always like get worried people say that when they have a lot of acidity that there can be an ulcer that can like perforate or something. Do you think something like that happened?
Oh, David, would have to find out when I'm done taking your history and do some examination. I would know if that's what's happening, okay?
Okay. I
Oh,
was just
yeah.
worried. I thought I'll ask.
Yeah, it's good you asked, but we'll do our best to make sure you're fine, okay?
Okay.
Okay. So, does this pain shoot anywhere?
No.
Okay. When you take a deep breath, does it get worse?
Yes.
Oh, so sorry. Okay. Like, did you recently have something like an like flu-like symptom recently?
No.
Nothing like that. Okay. And you said the pain doesn't shoot anywhere, right? Okay. So, do you have fever?
No.
Do you have any lumps and bumps on your body?
No.
How is your appetite?
Oh, my appetite is good.
Okay. Any change in your weight recently?
No.
Do you have any rash?
No.
Okay. Do you have any night sweat? So, do you have any urinary symptom?
No.
What about bowel changes?
No.
Okay, David. David, do you have anything like maybe leg swelling?
Yeah.
Okay. So, when did you notice this leg swelling?
I actually broke my ankle a week ago. So there's a cast on the right ankle, and I feel like my right leg is a bit swollen for the last 2 days.
Oh, so sorry. Okay. You went to the hospital and there was a surgery performed, right? Was there any
Oh,
surgery done?
no, there was no surgery. They just put a cast around it.
Okay, okay. Was there any recent travel?
Mm.
Okay. So now, David, I want to ask you some question about your past medical history since I'm seeing you for the first time, okay?
Okay.
Do you have any medical condition you're being managed for?
Only high blood pressure. I take perindopril for that.
Okay. Is there any medication apart from is there any other medication you're taking?
No.
Okay. So any recent hospitalization?
No.
Are you allergic to anything?
No.
Okay, David. So I want to ask you about your family history, okay? Do you have family history of any chronic medical condition?
Just the high blood pressure, high blood sugar. Nothing
Okay.
major.
Okay. So see what I want to ask you some question about your social health. What do you do for work?
I'm an accountant
Okay. Who do you live with?
with my wife.
Okay. Do you smoke cigarette?
No,
Do you drink alcohol?
especially.
You said occasionally.
Yeah.
Okay. Okay. So what do you drink?
Beer, a glass of wine.
Okay.
Yeah.
Do you use any recreational drug?
No.
Okay, David. I want to examine you right now. Okay. So this will involve being touching, feeling, and moving some of your is that okay?
Yeah, sounds good.
Okay. So do you have pain anywhere?
Um, just the chest pain.
Chest pain. Okay. So now I want to drip you appropriately. Can I have the vital signs of my patient, please?
Vitals were given. So
Okay. Yeah.
temperature is 37.2, heart rate 112, blood pressure 118/76, respiratory 24, oxygen saturation 91% on room air.
Okay. I think my patient's oxygen saturation is low, and my patient is tachycardic also. So now I
The
want to.
time is done, but we complete the examination.
Okay, now I want to drip my patient appropriately. David, can you take off your shirt for me?
Yeah, sure.
Okay, now I want to start by, can you bring out your hand? I'm checking if there is any pallor, any tremor. I'm checking if there is any, I'll do like this. Can you do like this for me? I'm checking for finger clubbing. So I'm checking the pulse, checking the heart, the rhythm, and the volume. I'm checking for radial synchrony, like the radial synchrony. So after that, I'm coming to the face. David, can you do this way for me? So I'm checking for pallor. Can you do this way for me? I'm checking for jaundice. So now, can you open your mouth for me, David? So I'm checking if there is any dehydration, any pallor, angular stomatitis, any oral ulcers. Now I want to check the chest. Okay, so I'm checking the chest. I'm inspecting the chest. I'm checking if there is any scars, any scarification mark, any erythema.
Nothing.
Okay, thank you. So now I want to check the centrality of the trachea. So I'm putting my hand and checking if the trachea is central or deviated, and I don't seem to appreciate any. So now I want to palpate. So I'm checking for tactile parameters. So can you say 99 for me? 99. So after that, I'm checking for chest expansion. So can you take a deep breath for me? Out. So
there was no tactile parameters. It was normal. Chest expansion is normal.
okay, thank you. So now I want to auscultate. So I'm auscultating for if there is any, no, I'm palpating, sorry. I'm palpating if there is, I'm percussing, sorry, because if there is any resonance, hyperresonance, Tony Doll. So I don't think there is none. So now I'm auscultating. I'm auscultating for breath sounds. I'm auscultating if there is any crepitus, any purity. Okay, I think I'm stuck. So now I'm checking the lung basis, checking if there is any crepitations, any
Okay. Is your exam done or you want to examine anything else?
yeah, I want to examine the leg.
Okay,
I'm
good.
checking the leg for if there is any presence of edema. Then edema,
Okay.
palpating for edema.
And in your lung examination, in whatever you're thinking, would like the differential that you're thinking, your respiratory examination, do you feel like there will be any abnormality or it will be normal?
There could be abnormality.
What kind of abnormality?
It could be pericardial
Okay,
fiction.
we'll talk about that. First, give me your differentials.
Well, differentials are pulmonary embolism, pericarditis, myocardial infarction, heart failure. I'm good.
Okay.
Yeah.
Now, given pulmonary embolism, so in pulmonary embolism, what kind of abnormal things you will find on the respiratory examination? Question is to everyone. Let's not put more in.
Crack.
I think we can, I mean, sometimes we can have decreasing breathing sound, but we can also have P2 for heart sound.
Excellent. So mostly your respiratory examination will be normal, and the reason I said that, like when you're saying tactile parameters, crackles, and all of those, I would say because those are like the things that you were looking for were very pneumonia specific. So you're doing a examination where you're looking for PE. So if you want to rule out that, you can say that just to rule out, I want to make sure this is like this just. But if the examiner asks you that what you're expecting examination, respiratory examination in pulmonary embolism, you should know that most of the time it can be a complete normal examination, or sometimes if the clot is big enough, there will be decreased breath sound. And then, of course, in cardio, you can have a split P2, but like sometimes even that is hard to figure out. But just to know that these are the things. Okay, what are you going to do next in terms of investigation and management for this patient?
Okay, for this patient, I'll do the blood work. I'll start by doing the blood work. I'll do the complete blood count and differentials. I'll do the liver function test, serum electrolyte, urea, and creatinine. I'll do the pulmonary angiography. Then I'll do the chest X-ray. I'll also do cardiac marking. I'll do the cardiac marking and random blood sugar and all the
So CT,
ECG.
yeah, so CTPE did show moderate clot burden. How will you manage?
Okay, for the management of these patients, I would start by making sure my patient is stable. I'll do the ABCD of resuscitation, then I'll set up IV access. while collecting the sample, cardiac monitor to monitor the vitals of the patient. Then I would give no warfarin. Oh my God. I'm having brain freeze. No warfarin. What's the other one? Oh, what's the other one? Help.
Anticoagulation. So will you give heparin or will you give DOAX?
Heparin. Thank you. I'll give heparin, not warfarin. I'll discharge you on warfarin, then I'll give heparin. Yeah.
But my question is, you will give heparin or you will just direct anticoagulants like apixaban, rivaroxaban, etc.
I'll give heparin.
Okay. And why heparin?
Yeah. I feel heparin has like a faster action,
Yeah.
like it acts very fast,
Quick
unlike the other
switch
one.
on and quick switch off. So
Yeah.
in the hospital, you start with heparin, but then ultimately switch to DOAC. Okay, good job, Maureen. Overall, it was nicely done. The most important thing is, again, patients can distract you with like giving oh, it was a burning pain, like a kind of GERD
Yeah.
history, but then you very smartly figure out that, okay, maybe he has this GERD history, but right now the pain is different, or um, you didn't like detract and kind of figure out that this is pulmonary embolism. So I'm not mean that I'm giving you all this mixed information and everything. This is how the Nagoski station. So the Nagoski is mean actually. So I'm just preparing you from the very beginning that keeping this like thing into your mind that okay, no matter how like it looks good, but we still have to figure out what else is going on, and then slowly you figure out he had a broken ankle, and then of course there's a right leg swelling, and he is most likely having a clot. You said that I want to make sure my patient is stable. What is stability to you when you say my patient is stable?
The vital signs, because the patient has the partial pressure of oxygen is low and the patient's heart rate is high. So I feel that I have to stabilize the patient's vitals.
Is it concerning for you?
It's not concerning, it's just like a sign showing that something is going on with the
If the
patient.
blood
So
pressure was 90/60,
yes, I'll be more
you-
concerned in that regard.
what would you have done different?
I would have set up an oxygen.
If the heart rate is 90/60?
Oh no, patients might be losing blood, like has reduced blood circulation.
If the blood pressure is 90/60, any one of you would have done anything different?
Thrombolysis.
Thrombolysis, excellent.
Okay.
Whenever, so why I asked the stability, and the reason is if I just tell you guys, you will forget it. But now because I'm teasing you a little bit, so you will remember. So stability simple means whenever we look at the vitals, um, if the patient is tachycardic, this is a common expectation. A patient with pulmonary embolism, a patient with fever, a patient with blah, blah, blah will have tachycardia, right? And then if their blood pressure is normal and if their oxygen is seems like low 90, he's 91 on room air, so he will need some oxygen. So even patient need 2 liter oxygen, 3 liter oxygen, I'm okay with it. The patient on 5 liter oxygen, 8 liter oxygen, patient on tachycardic, I'm okay because I know he's having a clot in his lungs. So these findings are expected, and I have to treat his clot, and then these things will get sorted out, right? I will get worried when my patient is like on 15 liter of oxygen, because then that means like with a normal nasal cannula that you give, you can only give like 7 liter of oxygen, and then through mask you can only give 15 liter of oxygen. After 15 liter, you have to go to OptiFlow, which can deliver up to 60 liter of oxygen, and after that it's intubation. You have to intubate the patient, right? So when the oxygen requirements are rapidly escalating, that's where I get worried. I'm like, ooh, where is my patient going to end up in ICU? That's where I get worried. So oxygen wise, someone on 2 liter, 3 liter, 4 liter, I'm okay because any sick patient will need a little bit of oxygen, right? But rapidly escalating oxygen requirements, you need 10 It was 5 liter, now 8 liter, 10 liter, 14 liter. I'm like worried, where my patient is heading. Seems like my patient is heading towards ICU, or my blood pressure is dropping. That is like where I'm worried. So 90-60 unstable vital. So we won't be putting patient on heparin. This is an indication for thrombolytic. So this patient, so why I mentioned this, that vitals are very important when they are given, and even when you will ask and they give you vitals and vital are unstable, they change the whole management. So for example, anyone having arrhythmias but vitals are normal, you give them their beta blockers and all of those and control the heart rate. But if anyone with arrhythmias and their vitals are unstable, it's like immediate cardioversion, right? So vital decide the whole fate of the patient. Vitals tell you that whether the patient is stable or non-stable. Unstable patient will need urgent intervention. So in terms of PE, it will be thrombolytic. So you will give them thrombolytic, but after ruling out the contraindication, do not do more harm. Um, this patient had, like, for example, stroke a month ago. Now you give them thrombolytic and they didn't die of PE, but they did die of a whole brain bleed. So these are, NACOSC is a safety exam. Make sure that you're a safe doctor. So you won't fail the exam by making mistakes. You will fail the exam by not a safe doctor. So we will talk a little bit more on the management of pulmonary embolism, and also when to do imaging or not, like what is Wells criteria and all of those, but next week. So you guys have homework between now and next Monday. Find your study partners. If you don't have, start practicing. Go through all the cases that we did in the class, make new cases for each other, essentially go through all these topics. So revise all of this, but then also prepare the other topics so you come prepared to the next class. I'll see you guys next Monday. Take care. If you have any
Thank you
questions,
so much. Have a good night.
have a good night. Feel free to write in the
Thank you. Dr. Samina, the next class is at 6 p.m.
It's 8 p.m. Toronto time, 6 p.m. Alberta time. Yes.
When is that? What day?
Bye.